You're muted.
Thank you. Good morning, everyone. Welcome. This is Kate Winsek. I'm the coordinator for this P2P workshop. Welcome to day 2. If today's your first day joining, thank you for being here. We'll do a quick review of the housekeeping items for today's meeting before we get started. And Catherine, are you doing the slides or me? I forget. Okay, great. So again, welcome to this Pathways to Prevention workshop on rural telehealth. We're glad you're here today. You can find the workshop agenda, speaker bios, and other workshop resources on our website, the Office of Disease Prevention website, at prevention.nih.gov /P2P rural health. We have a couple of ways for you to comment and ask questions today. You can use the WebEx Q&A pod during the discussion sessions. It is at the bottom right of your screen, and submit questions to all panelists. You can email us at nhp2p@mail.nih.gov or join the conversation on Twitter. If you have technical difficulties, please use the WebEx chat pod and send a message to all panelists. So the chat pod is just for technical difficulties, and the Q&A pod is for questions for our speakers today. We have closed captions available, and you can view the closed captions for this workshop. Oops, hold on a second. You can view the closed captions for this workshop in the multimedia viewer at the bottom right corner of your WebEx window. And zooming in on content, you can make content appear larger or smaller on your screen using the magnifying glasses found on the left side of your WebEx window. You need to kind of hover your cursor over the left side of your window to make it bigger. Next slide. And so we have a couple of opportunities to comment on products that are coming out of this workshop. Starting yesterday, the first day of the workshop, you can review and comment on the draft systematic evidence review that was prepared by the Pacific Northwest Evidence-Based Practice Center. And you can find the link for that report, which is open for public comment for about a month, again, starting yesterday. You can find that link on our website, on the ODP website. And then also in roughly February 2021, you can review and comment on the panel's draft report. So the panel that is overseeing the workshop today will write a draft report summarizing the workshop and providing recommendations for future research priorities. And again, that'll be available in winter 2021 on the ODP website, and we welcome everyone's comments on that report. And lastly, sorry, next slide. Lastly, please complete the post-workshop survey. At the conclusion of this 3-day workshop, so tomorrow, all registered attendees will receive an email from NIH P2P Logistics at westat.com with the survey link. It'll only take about 5 to 10 minutes to complete, and we'd really appreciate everybody's participation in that. It helps us improve the P2P program. Next slide. So join us for day 3 tomorrow. If you're not planning to already, starting at the same time, 11 Eastern, we will cover the following key question tomorrow, key question 4, which is what are the methodological weaknesses of studies on provider-to-provider telehealth for rural patients, and what improvements in study design might increase the impact of future research. So again, that's tomorrow. You need to register for each day of the workshop separately, and you can do so on the ODP website. Next slide. Next slide, please. That might be it. Okay.
I think that's it.
Okay, thanks, Catherine. So I will now turn the workshop over to Dr. Mary Wakefield. She is our workshop and panel chair, and she'll do a quick overview of a recap of our day 1 yesterday and introduce today's objectives and key question 2 and 3 for today. Thank you, Dr. Wakefield.
Thanks, Kate. Welcome, everyone. We're delighted that attendees are able to join in this workshop. And today is, as Kate indicated, the second of 3 days of presentations and discussion. Before I mention the topics of the day, I do want to point out that we do have a discussion section following each one of the panel's presentations, the set of presentations, but I'll be going to my colleagues first to invite their comments and questions of the panelists. And then we'll open it up to taking questions from the audience. So there is no time limit on my colleagues' questions in that discussion. But once we've heard all of those, we'll immediately turn with whatever time is available remaining to taking questions from all of you. So with that, just a mention of yesterday, we had just some terrific opening presentations that helped to set the stage for the topic that we're here talking about. And we took on the first of the 4 key questions that are being used to frame these entire 3 days. That first question that was considered yesterday through both presentations, through the sharing of evidence, and through discussion, focused on the uptake, trying to better understand what the uptake is of different types of provider-to-provider telehealth, particularly, of course, in rural areas, since that is our focus. Today, we're going to pick up on the second and third of the 4 key questions. The first of those questions that we'll take today is going to focus on the effectiveness of provider-to-provider telehealth for rural patients. So really trying to drill down more explicitly on that overarching focus. And then within that, we'll take on some a subset of questions, including looking at what provider-to-provider telehealth, how does it affect outcomes for patients and for populations? We'll also take on what the benefits are to healthcare providers of provider-to-provider telehealth for rural patients. And then finally, under that overarching key question to how does provider-to-provider telehealth affect outcomes for private and public payers? So that's the set of subset questions underneath that broader overarching question, focusing on what is the effectiveness of provider-to-provider telehealth for rural patients. Later today, we will pick up the third of the 4 key questions, and that focus is on the strategies. That is, what strategies are effective and what are the barriers, what are the facilitators to implementing and sustaining provider-to-provider telehealth, again, in rural areas. So that's our agenda for today. We'll also have some keynote remarks that should be very informative during the course of the day. And with that, I'm going to turn it back to you, Kate. Again, welcome to everyone. Thanks for being here. Kate?
Thank you, Dr. Wakefield. Now I'd like to introduce Dr. Annette Totten from the Pacific Northwest Evidence-Based Practice Center, who will share the systematic evidence review results for key question 2. What is the effectiveness of provider-to-provider telehealth for rural patients? Go ahead, Dr. Totten. Thank you.
Thank you. Good morning. Welcome back to those of you who are joining for the second day. This is the second of 4 presentations on the systematic review. And as Kate said, I'm associate professor at the Oregon Health and Science University and part of the Pacific Northwest Evidence-Based Practice Center. If you could go to the next slide. My team and I don't have any financial disclosures to make. We do need to say that this presentation is our responsibility as well as the report, and not necessarily the it's not endorsed by AHRQ or NIH, any of the specifics, although they did contract for the work. If you could go to the next slide. To start, I just want to situate the presentation. I think Mary already did that, so I'll just quickly say that if you'd go to the next slide, that this is the second question. This is the most traditional systematic review question in that it's a comparative effectiveness. It asks about the effectiveness of provider-to-provider telehealth. If you go to the next slide. Just the specific focus, though, is on outcomes, not just for patients and populations, but we did also look at outcomes for healthcare providers and outcomes for payers as well, or looked for research to see if those were included. If you could go to the next slide. So quickly, for people who were here yesterday, this is a recap, but for anyone who's new, we want to make sure that we're clear about sort of the definitions for the review. So we use a broad definition of telehealth, which is the use of telecommunications technology to provide healthcare across time or distance space. So it could be locations. That means it can be synchronous, asynchronous. We didn't focus on specific modes. We included video, text messaging, web apps. We included functions, different functions of telehealth. Telehealth for provider to provider can be used for consultations, for mentoring. So we'll see some of those different functions as we go through the evidence, and a wide range of clinical indications. And this is one of the challenges, as was highlighted by some other speakers, that telehealth is quite broad. Once we narrow down to the focus of this topic, which is provider to provider, our definition for that focuses on any interaction between healthcare professionals when caring for patients or populations in rural areas. We let rural be defined by the studies. We didn't have an absolute definition of rural. If you'd go to the next page. So I'm not going to spend much time on methods, but I just want to highlight a couple of things. If you'd go to the next slide. So the detailed methods are, there's an overview in the first presentation, and then there's extensive protocol embedded in the report, both a summary in the main text and in the appendix. But just to highlight, this is the presentations during the workshop are based on the draft report, which is posted right now. The final report will be updated through this month, and we're in the process of doing that right now. And that in general, our methods follow ARC standards. That are one of the key things is dual review of abstracts and studies, as well as applying established criteria for evaluating both individual studies and the body of the literature. If you'd go to the next slide. So specific things I want to mention about related to this particular question is, because this is the traditional comparative effectiveness question, one of the key steps in the review is then synthesizing evidence across studies. In this particular review, we did not use meta-analyses because, as you'll see, we have a limited number of studies. While there's quite a few studies, you'll see there's included in this review, in this part of the review. Once you break it down by the type of telehealth or the outcomes, you don't have enough to really numerically combine the results. So we combine them in a qualitative way. We use an approach referred to as strength of evidence, where we rate the confidence in our confidence in the stability of the results across studies. And that is explained in excruciating detail in the report, and I'm happy to answer questions, but I'll try to explain it more as we go along. If I could have the next slide. So now we get to dive in to the results. First, I'm going to provide a description of the included studies, and then I'll go into specific results by healthcare settings, which is how we organized the report. Next slide. So we had, this is the counts and the percentages of the effectiveness studies across the different settings. We split things into inpatient, outpatient, emergency care, and then the education and mentoring types of uses of telehealth. So inpatient includes, and you'll see this soon, consultations, both synchronous and asynchronous. For inpatients, it also includes the use of remote ICU technologies. Outpatient includes a wide range of different uses of telehealth for consultations. Emergency care includes things such as telestroke programs, both in EDs and in pre-hospital care. And then education and mentoring is where you'll see the ECHO program studies and other video-based training and remote mentoring studies. If I could have the next slide. So we also have a wide range of study designs. We didn't exclude, as I said yesterday, based on study design. So we did find randomized controlled trials, a lot more observational studies, and a distinction that's important for telehealth is what we call before and after the implementation of telehealth, often in the same organization, but different patients, right? You'd be reporting on the mortality before telehealth and then after telehealth, and it would be a different group of patients. Pre-post is the same participants. That's predominantly in the ECHO programs, where they look at the participants in the ECHO before and then after. Although occasionally we have found some telehealth studies that are actually pre-post with the same patients. And then we rate each study by risk of bias. So that's an individual assessment of each study. The criteria depend on the study design. So what makes a good RCT is a little different than what makes a good cohort study. And all of those criteria, and as well as the specific ratings for each study, are included in the report. If you could go to the next slide. Just briefly, some study characteristics for these studies. Most are in the US. Most are between 100 and 500 subjects. Most are video, and the most frequently reported outcomes are patient-level outcomes. Next slide. So now we get to the actual setting findings by each setting. What I'm going to do is give you a quick summary of what we found and then show you what the detail looks like so that you can then follow it up in the report if you want. We sort of have 3 levels we do things. We try to roll it up at a very high level. Then we try to summarize by outcomes. Sorry. And then we provide details on individual studies and evidence tables, which are included in the appendices of the report. So if you would go to the next slide. So I'll spend a bit more time on this first one on inpatient so that it makes sense as we go through each of the other settings. So in inpatient, we identified 12 studies that looked at the comparative effectiveness of provider to provider telehealth, focusing on rural patients or populations. Most of them, 8, were these before-after designs. So they measured stroke mortality before telehealth and then after they implemented telehealth. So different patient populations, but the same organization, sometimes multiple organizations. And then most of them were in the United States. So then when you look at those studies, they sort of fall into 3 groupings. The first grouping are telehealth consultations at rural hospitals versus an in-person or a phone consultation. So we have a group of 5 studies that reported length of stay and found, basically, you'll see in the next slide, similar lengths of stay, and 2 studies that reported transfer rates. So the outcome is summarized right below the types of studies. SOE stands for strength of evidence. And like I said, the details on how we get to the strength of evidence assessments are in the report. Essentially, we look at the quality of the studies included, how consistent the results are, how precise the estimates are. And a lot of the issues with these studies is that they're weaker study designs. Like before-after is a relatively weak study design, particularly if it doesn't control for effects of history. Or a lot of the studies, the smaller studies, don't necessarily have power to detect a difference, and they're reporting similar, that there's no difference, but they didn't really have the power to detect it. So we'll talk a lot more about that when we get to key question 4. But overall, the telehealth consultations on these studies resulted in similar lengths of stay and similar rates of transfer. The care of neonates at rural hospitals, there are 2 studies that looked at that and found that they had similar clinical outcomes if they stayed in the rural hospital and had rural health consults, as opposed to transferring to a hospital with a higher level of care. And then there was only 1 study, this is kind of interesting, we'll talk about that in a minute, of remote ICUs in rural areas. So this is sort of the overall summary of inpatient. If you go to the next slide. So this is what the results, the higher level results summarized by outcomes look like in the report. So we try to provide an overview of the patient outcomes that are important, in this case, mortality, hospital use, and other clinical outcomes, and then provider and payer outcomes if they were reported. We tell you what the outcome is, and then the symbols tell you if telehealth provided an advantage. If it's a tilde, it's equivalence. If there's a minus or a dash, that means that it was worse with telehealth. And then mixed means that the outcomes were so varied we couldn't come to a conclusion. Throughout these presentations, the superscript numbers are the citations in the draft report. Those will change when we get to the final report as we add more studies. So I know it's a lot to see, but I wanted to give you an idea of what these look like. So for example, infectious disease, there's 2 studies, both of them reported improvement, that is lower mortality with telehealth, equivalent numbers of transfers. The length of stay did go up, which in general is, in this case, maybe a good thing, but it's as explained in the report, the way it's defined, that's why it's a negative. And then improved use of antimicrobials. If you'd go to the next slide. So the other areas we found in inpatient were neonates, as I mentioned. And so this shows the summary of the types of outcomes and the findings with neonates and the use of telehealth, and then the remote ICU. Remote ICU is an interesting one because it's one of those uses of telehealth that's advocated for quite frequently, but that actually most of the research, and this came out in a prior report we did, most of the research evaluating remote ICUs is actually in urban areas, is in health systems that use them to deal with shortages of intensivists. They haven't, while they're used in rural areas, the published evaluations are quite limited. If you'd go to the next slide. So now I'm going to very quickly do the same thing for outpatient ED and the education settings. So if you'd go to the next slide. So in outpatient, we had 23 studies, many more RCTs, about half in the US. And these tended to group around certain conditions, have been more studied. So the most frequently studied, or ones with consistent findings, are diabetes, and you see improvement in depression in diabetic patients, improvements in clinical outcomes and self-management, and improvement in blood pressure with the use of telehealth consultations. The patients with depression, you also see some improvement. As when I get to the details in a minute, you'll see it's a little more complicated. If you'd go to the next slide. So in depression, one of the complications is that there are very different patient outcomes measured, and they're often measured at different points in time. And in the study, something will improve in 6 months and then be the same in 12 months and then be different at 18 months. And the response, remission, depression-free days. So one of the challenges is that there's a lot of different outcomes measured in the depression studies, which makes it a little hard to summarize, but we try to sort of give you a flavor of all the different outcomes and which ones you can definitely see. The clearest improvement is in medication adherence. In terms of response and remission, it's a little trickier because the studies report mixed results, so it's harder to summarize. One of the interesting things in depression is also the payer outcomes. So this gets a little challenging because it depends on cost to whom and for what. So the couple of studies that have been done do find increases in some types of costs related to use of primary care and then decreases in other costs. So that's why in a wash in some cost effectiveness analysis, it's cost effective, but there are going to be increased costs in utilization at some points in the care spectrum and not in others. If you'd go to the next slide. So like I said, outpatient is messy. There's a lot of different clinical uses that the outcomes are different, so it's very hard to combine. So here's an example. We have one study each for PTSD and ADHD. If you go to the next slide. This is the diabetes studies that were mentioned in the summary. We had 3 with relatively consistent results, so we feel a little bit more secure in saying that telehealth is effective for patient outcomes in diabetes. There's one study in screening for neuropathy, which is a very different outcome, and then another study that had to do with fractures. If you'd go to the next slide. Other topics besides diabetes and depression and mental health that are covered in outpatient that we actually found specific studies on rural Outpatients are hepatitis C, rheumatology, oncology, and hemodialysis. If you go to the next slide. Other topics where we found one study, so we do report those, but one of the challenges, particularly when the studies are not large and most of them aren't RCTs, is that one study is rarely sufficient to lead to a strong conclusion. So we do report these, and sometimes we try to summarize across all of them, but the outcomes for telepharmacy are very different than the outcomes for dementia care. So sort of summarizing others is a little tricky, but we provide the details hoping that will help inform more discussion and decisions later on. If you go to the next slide. So fine, I've got the other two settings to do, and I think I'm doing okay. I'm watching the time. But so the next group is emergency care. So if you'd go to the next slide. So this was, again, a relatively large, not a huge body of evidence, but 25 studies. Emergency care is much harder to do randomized controlled trials in, so most of them were cohort studies, including, again, 7 of these before-after designs where they report outcomes before and after implementation. Most of these were in the US, but you'll see from this first bullet, they cover a wide range of different conditions: stroke, heart attack, chest pain, critical care and trauma, some providing consultations for multiple conditions, and then again, some topics where we had one study, such as sepsis, suicide, and sexual abuse, or suicidal ideation. There's a word missing there. So we tried to group the telehealth consultations that have to do with stroke and heart attack and pain, where the main outcome was mortality and time to treatment, where the objective of the telehealth was to make a decision about whether to transfer the person or not, whether the care could be managed with supplemented with telehealth in the rural location, or the patient needed to be transferred. If you'd go to the next slide. And so this is broken out by stroke, heart attacks, and chest pain, and the different modalities, mostly video conference, but also text triage, and also transmitting ECGs, sorry, it's early for me, and having a specialist interpret them and advise on whether the patient could be treated in place. For the most part, you don't see a difference in mortality, which is good. We would hope that people are not dying more if they're staying at the rural hospitals and being treated. You do see, in some cases, improvement in mortality, because it may be that that patient never would have been transferred or would not have been transferred fast enough. You do see equivalent time to treatment. So for example, in stroke, that the time to TPA is equivalent, which is a good sign that if the telehealth can make sure the person gets the TPA in the same time, and actually some improvement in getting it within 3 hours. So these are, indications that this is a use where for stroke, heart attack, these types of assessments, that telehealth can help with the decisions about where to treat someone without adversely affecting most patient outcomes. And there are a couple that are mixed, but most of those have to do with time, the arrival to balloon for a STEMI and arrival to ECG. And some of those are a little tricky because the measurement of time when it starts varies in these studies. Like, does it include the ambulance time? So is it from call to arrival, or is it from ED door to the treatment? So if you go to the next slide. The other group of emergency care findings have to do with providing telehealth consultations for the treatment of critical cares and traumas in emergency departments. So in this case, the patients are in the emergency department, and the consultations are about how to actually treat the patients. And in general, these, similar to the others, these do avoid transfers. The critical care, one of the studies was of children, and so you have patient or guardian satisfaction for not having to have a pediatric patient transferred. who didn't need to be. You do see improvement in how long that is. So improvement means it's a shorter ED length of stay, and time to arrival at wherever the people are actually finally treated. So in general, we try to summarize across these kinds of outcomes and say that telehealth improves outcomes for emergency, trauma, and critical care. If you could go to the next slide. The education and mentoring is the most different of all the settings. And in the other reviews, I've done a few telehealth reviews. These haven't always been included. So this is a bit different. So if you go to the next slide. So the education and mentoring study. So this is using telehealth to provide education and mentoring to providers who care for rural patients. And we identified 19 studies that evaluate these programs. 10 are echo, 5 are video training, but not echo, 3 online courses, 1 text messaging. As I mentioned before, several of these studies are sort of pre-post. So they measure something about the participants before the echo or before the training program and after. There were a couple of RCTs and a couple of other cohort studies that followed people over time. It's important to note, again, that these covered a wide range of topics, the most common mental health, but also liver disease, diabetes, and childhood obesity, dermatology, or one echo multiple conditions. Overall, the studies report patient outcomes, which are not most of them. Most of the studies of echo and training programs don't report patient outcomes, but there were 2 studies we found that did report patient outcomes, and they both found improvement in the patients of the trainees. So in a diabetes echo, the A1C of the patients after the echoes improved, and in a changes in prescribing, changes in screening, and changes in patient counseling. However, one thing to note is a lot of times the follow-up is short, and that's something we can talk about when we get to key question 4 tomorrow, is, how much of an impact and how persistent is the impact of these programs on provider behavior. And then once you get past behavior, just more toward attitudes, confidence, participant scores do improve on those things. If you go to the next slide. So again, here's details on the education and mentoring findings. So you can see the echo programs were specific to antibiotic therapy, diabetes, liver disease, and the most frequently studied were mental health. And in general, the provider outcomes are positive, as well as the patient outcomes that are reported, but they frequently aren't reported. If you go to the next slide. The non-echo video conference types of training are similar, covered very different topics, but also find that the provider outcomes are positive, but very few patient outcomes reported in those studies. If you'd go to the next slide. And then finally, we had 3 studies of an online education course for mental health, which also reported positive provider outcomes, and one study of a short messaging service that provided sort of mentoring to primary care clinicians. Right, so if you go to the next slide, so I can wrap things up. So a very brief, overly high-level summary is coming next. If you'd go to the next slide. So provider to provider telehealth, our overall sort of conclusion on the effectiveness is that, and we say may provide benefits because of our concerns about the quality of the studies and the consistency, but these are the areas where the evidence is the best, is for inpatient care, neonates in rural hospitals, outpatient management of depression and diabetes, and emergency care for stroke, heart attack, or chest pain. If you go to the next slide. And that telehealth for provider education can improve patient outcomes. We should study that more. Changes provider behavior and increases provider knowledge. We're just not sure how long the provider behavior change lasts. And that other uses, there's other uses and outcomes, but with single studies or small studies, it's hard to come to a conclusion. And then the last point I want to make before stopping is that one of the concerns is that harms or negative outcomes are often not even considered in these studies. So on the one hand, it's encouraging that we don't find them, but on the other hand, we're also concerned that people may not be looking. If you'd go to the next slide. Next slide. So just a reminder, and there's 2 ways to get to the report, and we'll make sure we put them all in the chat, both from the Effective Healthcare site and from the P2P site. But the report is available for a 4-week public comment period. Since I'm actually on time, the other thing I'll tell people is that after the public comment period, it will disappear, and then it will reappear in the final form. So if you're interested in reading the draft report, even if you don't have time to comment on it, you need to download it during the 4-week public comment period. And I think if the next slide is just a repeat of the names of our team, just to acknowledge that everybody, these are sort of big reviews, and we have wonderful research staff. And then the final slide is the NIH and ARC staff who supported this review. So that's presentation number 2. Thank you. I'll hand it back to Mary.
Actually, I'll take it, Dr. Totten. Thank you so much. This is Kate. Key question 2 out of all 4 key questions in this evidence review has the most data. So thank you for being so thorough with that presentation. So now we'll go to our next presenter in key question 2, Dr. Stanley Zeppler, who will present on provider-to-provider telehealth outcomes in asthma, the example of rural patients and populations. Thank you, Dr. Zeppler, for joining us today.
Thank you, Dr. Wakefield. And I'd also like to thank Dr. Melissa Green Parker for inviting me to participate. It's been a very educational experience, just learning about the session and being encouraged that rural patients and providers are getting some consideration. I'm the director of the Pediatric Asthma Research Program in the Breathing Institute at Children's Hospital. And then for the last year, I've been the interim medical director for the Research Institute at Children's Hospital, Colorado. And interestingly, we just got named, got an award for digital health. And so we have been playing a large role in that area. Next slide. Next, yes. So I do have some disclosures. The majority of my work is with NIH. And one area is called the Precise Network for Severe Asthma. But the most important study that I'm doing right now, sponsored by NHLBI, is on disparities elimination and coordinated interventions to prevent and control heart and lung disease. And I'm very honored to have this award because it really builds on the success of our Colorado Department of Public Health school-centered asthma program. And I also work in the electronic medication monitoring area, as well as serving on several advisory boards for pediatric labeling of asthma medications. Next slide. So in reflecting on the last day and this morning's presentation, I would like to convince you that asthma is a ripe area for looking at telehealth, particularly in the rural communities. And what I'll do is discuss current status of provider-to-provider telehealth, indicate how provider-to-provider links can be established for asthma care in rural communities, and also to kind of project the next steps in the evolution of telemedicine to assist children with asthma in these rural communities. Next slide. So I looked at the literature and I really pay attention to the asthma literature. I couldn't find anything on telehealth and effectiveness. So what I decided to do was take a frontline perspective and talk to people that are actually in the trenches managing patients in the rural communities, and then also talking to our providers in the Breathing Institute and the hospital who are working in the telehealth area, and then several people who work with me in developing our work in the rural communities. Next slide. So in terms of clinicians and in terms of asthma, there's been an evolution. If you look at the last 50 years in terms of medication development and care of asthma. And there's kind of two tiers that we're working with. Now, there's an emphasis on population health. And I would say our school program is a model for that, where we try to pick out children with asthma, look for the ones that are not doing well, and then provide them some assistance. But on the other hand, the science and the medications have moved. And now we're at an era where we can apply personalized medicine approaches to identify patients at risk for exacerbations and those who would respond to one medication or another. Next slide. However, there's a price to pay in all this evolution. And I think a useful book for everyone to read is this book called Uncaring by Dr. Robert Pearl, who was a CEO in Kaiser Permanente in California. And it talks about the impact of all these changes on the clinician and also the healthcare system. There's been a loss of autonomy, there's been a loss of relatedness, and there's also been a loss of competency in all these areas that have moved along in the last 50 years. And people go to medical school to help patients and to establish relationships. And a lot of that has been fragmented now. And this book covers that very nicely. But we're also trying to pay attention to social circumstances. And so everything that's been happening over the last several years have really impacted clinicians and contributed to burnout and stress in the healthcare system. So next slide. So in talking to our expert in telemedicine, I told her about the conference and she said, well, what are the outcomes? What's the purpose of the conference? And she broke it down into several areas, which I thought were interesting. One is what's the impact on clinical care? And you can measure that quite easily in terms of hospital admissions, ED visits, after-hour calls. What's the effect on parents and children in terms of asthma knowledge, regular care, self-management? But I think the other big part is what's the effect on the community? Can you enhance the standard of care? And how do you measure that? And things like medication availability in the pharmacies is a challenge. Schools have a distance. And so how do you communicate and enhance collaboration? And then how do you increase the capacity for severe asthma management, both inpatient and outpatient? Next slide. So what was provider-to-provider telemedicine like pre-COVID? Very limited application. Rural providers called for consults for individual patients. They often didn't know who they were calling. They referred patients who could wait for a few weeks to get in for a consultation because of the backup. And they made calls to consult services for immediate assistance and transferred patients with high acuity. Next slide. So the big challenge, COVID changed everything because it had an impact on our system. Within weeks, we converted rapidly from outpatient care to telemedicine to reduce exposure. But you have to look at it in terms of, do you think the glass is half full or half empty? And there are a lot of advances occurring in digital health, which go beyond just provider-to-provider communication that I'll talk about. Next slide. So where are we now? We did a rapid shift. We purchased telemedicine equipment. We trained clinicians. We assisted patients and parents with telemedicine visits. A lot of adjustments within a short period of time. And then we did scheduling changes to accommodate choices. But after a while, patients adapted to this, and some preferred the telemedicine, but others really looked to the personal visit. You know, even despite our social distancing cautions now, they really preferred the relatedness. Next slide. So what we have to ask ourselves is, what is the new normal going to be? And some patients prefer in-person visits. The technology, thankfully, is rapidly developing. We adapt to patient preferences. However, there is inequities that must be addressed, including the rural communities. And we see some similarities in the urban areas, but a lot more in terms of the rural communities, like things that were mentioned yesterday, bandwidth, connectivity, all those kind of things. Next slide. So there are some ways that you can apply digital health, and some of them can be synchronous, that requires coordination. Some can be asynchronous, like some of the examples yesterday, highlighting an interview and transferring the whole interview is innovative. But now we're really looking at things like wearables, chronic care measurements in terms of oximetry monitoring, where we can really get a handle on emerging exacerbations. And I think that's the exciting area. How can we catch them early and also monitor carefully? And then you can also use it for education, both in terms of providers and patients. And then also what we've gotten into is teleresearch, you know, being able to involve patients from a distance. Next slide. So what are the barriers? In talking to my pediatricians in the communities, they really like to do the in-person visits because of physical exams and procedures. But there is some convenience in terms of children not missing schools, maybe be able to coordinate visits actually in the schools where the parents can come as well. And it really depends on the number of patients they're seeing. If they're seeing 10 patients a day, they can move in a telemedicine visit. If they're seeing 25, that's much more difficult. And then the high acuity patients really have to depend on the expertise of the local hospital, and that can be limited. And also, it depends on what network you're in. That was not mentioned yesterday, but it can be configured to your network of care. And so you may have access to only certain consultations and not expertise. And there's a big difference between getting these consults in the urban setting versus the rural setting. In the urban setting, you can have face-to-face familiarity with the specialist you're calling. You can do immediate consults. There's a mechanism. And you can refer for immediate assessment by a specialist within a short period of time, depending on the urgency. And there is time that it takes to prepare detailed summaries. So sharing electronic medical records can help in those areas. Next slide. So for those who haven't experienced it, telemedicine is not another Zoom meeting. One has to make it convenient for the parents and the patients, hopefully getting the child together with the parent. It does have a benefit in limiting school absence. It does require the technology. It requires a privacy area. So multifamily homes, it can be inconvenient. It could be a reduced cost for the patient. And there's the potential to increase inequity the more complicated you make it. For the clinicians, there is an inconvenience because if a patient is late, that really alters the schedule because there's technology involved. There is the potential for missed visits, and that creates a gap in the clinician's schedule. There's an investment of equipment. There's limitations on physical exams and procedures. However, some of those things are being met by digital health. And there's a different reimbursement procedure, as was discussed yesterday. Next slide. So the advantage that I have now through NHLBI is through the Decipher network. And we're really taking steps to understand the communities and their interactions. Next slide. And in our setting, we have 7 members of this alliance. Most of them are in large cities. Most of them are adult oriented. But we took on the challenge of looking at the state, looking at pediatrics, and looking at asthma. And you can see here the distribution throughout the state. Next slide. This was an interesting study that was done by the Academy of Pediatrics and shows the difference, the distance that patients and parents have to travel in order to see a specialist. And you can see the density of specialists. You can also see the distance. So right there, in terms of pediatric pulmonology, you see the long distances they can take. And you saw in the previous slide where we spread that out to address these differences. Next slide. So what about the advances in medical care and technology? Right now, we're getting hit with streams of information, but that information can be very useful because my colleague, Dr. Diederding and Dr. Messenger put together, time for a visit is very limited, but is that good enough to get the good picture? And that's the way we're looking at asthma, is as a progressive disease in some patients that may ultimately evolve into COPD. And so we really need to look at the life course of the disease. Next slide. And the medical information's expanding. How can one keep up with it? I deal with asthma 24/7, 365, and it's hard for me to keep up with, let alone people in rural communities who are dealing with different circumstances and multiple diseases. Next slide. So we have to put this all together. And what could the future look like to improve asthma outcomes in rural communities? So I think we really need to take what we've concentrated on in the urban cities and move it to the networks of care, extend them, involve the core specialists in terms of integrating more closely with those rural communities. Rural in-person clinic visits can be conducted with specialty consultation if you time it right. There can be shared electronic medical records to reduce the timing of putting together summaries, but that information needs to be consolidated as more information is gathered. School and community-centered programs like ours, I think, can enhance care coordination if you start to break down the silos and build bridges. We can apply digital monitoring, especially in at-risk patients. And we can come up with unique techniques to bridge the rural provider with the specialty clinics. And I think there's ways of doing that. Next slide. So we have to also take into consideration some of the baggage that comes along with technology in terms of cybersecurity, telehealth and remote care extension, sharing electronic medical records, and then on the other hand, looking at this big data. So there are some things to look at in the big picture. Next slide. So I tried to put this together in terms of a lifespan way of looking at asthma, and we have some unique opportunities nationally to really have an impact, not only on exacerbations, but long-term outcomes. Next slide. And so it really requires an integration of a number of pieces of information: lung function trajectories, asthma severity index, biomarker to predict medication response, adherence monitoring, and then also social determinants of health. Next slide. So the big picture, and everybody's becoming now aware of social determinants of health. When I spoke about it about 4 years ago, there was questions from the audience in terms of what that meant. But now we're getting a better feel on it, and our hospital's taking a big role in trying to understand resources and the way to help patients in this area. Next slide. So the clinical implications is that now we have to look at asthma as a lifespan disease. We can use biomarkers to predict exacerbations and also response to medications. We can monitor patients' behaviors around medications. Refills is not enough. You really kind of need day-to-day information. We can assess social determinants of health and link resources. We can apply more potent medications to potentially alter the course of the disease, and we can monitor the outcomes. Next slide. So we've talked about patient-centered care, but we really have to look at that in terms of the population and the community and really change our perspective in terms of management. Next slide. So some of my recommendations, next slide, please, include the following. We must continue to establish provider-to-provider links with various mechanisms. We can use it most expeditiously in terms of education. Those things are in place. We need to look more expansively at digital health and what it can provide in terms of life course management. Bring the picture of social determinants of health into this. And we can also use machine learning to anticipate and manage patient exacerbations or loss of control. So next slide. Again, I'd like to thank the sponsors, Dr. Wakefield and the panel, for inviting me to participate. I welcome any questions on the question and answer or the chat, or you can email me directly with the address I provided. So thank you again very, very much for participating.
Thank you, Dr. Zeppler, for that presentation. It was great to hear this perspective from the asthma perspective, so thank you. And now we'll hear from Dr. Kelly McGrath, who will present on telemedicine in rural frontier Idaho as a tool to deliver sustainable, high-value healthcare. So thank you, Dr. McGrath, for joining us, and go right ahead.
Yeah, thank you. You could, next slide, please. Well, I'm Chief Medical Officer of a rural health system in north central Idaho. We've been using telemedicine for about 12 years, and with regard to key question 2, really, I think describing the implementation experience around telemedicine and how it can deliver high-value healthcare. We have been doing telemedicine for about 12 years in our environment, and we really believe that it's a key fundamental strategy as we go forward, particularly looking at alternate payment models. We are a 2 critical access hospital system with 9 clinics dispersed throughout our service area. We were acquired in April 2020 by Kootenai Health out of Coeur d'Alene. It was an interesting time to go through an acquisition. And they serve as a tertiary referral hub for us, but we remain the rural healthcare arm of the system. We believe very much that telemedicine is a strategy that will deliver a value to our patients, to the populations we serve. We see that it helps our providers, and we believe, particularly with alternate payment models, that it delivers value to the payers as well. I have another role, which is that I'm the medical director for the Medicare Quality Improvement Organization for Idaho, and as the Medicare QIO, we're certainly tasked at looking at value for the Medicare beneficiaries in Idaho. And Idaho is a rural state. About 1/3 of the population lives rurally. And it's clear that telemedicine, particularly provider-to-provider telemedicine, can serve as a way of addressing some of the disparities that really create a problem for us in our communities. The pictures there you see are the 2 hospitals in our system. We serve about 30,000 patients dispersed over a landmass about the size of the state of Massachusetts, for those of you on the East Coast, to give you a perspective. It's a frontier and rural communities. I have practiced most of my clinical time at the hospital on the left, which is in Orofino, Idaho at Clearwater Valley Health. Our other hospital is about an hour away in Cottonwood, Idaho at St. Mary's Health. And you can see, maybe just make out the Clearwater River behind the hospital. We're right on the river there, and that's about where Lewis and Clark put their canoes in the water on their journey west, over 200 years ago. And you can travel about in our area, and a lot of the area, I think, looks very much like it did when Lewis and Clark came through. I can tell you one thing, though, that has fundamentally changed in my experience of 28 years of providing full spectrum of rural family medicine in this hospital is that, you know, when I came, crazy as it is to say it now, the tools I had to deliver high value healthcare was really what was in my head, the books that might be on a shelf, and maybe who I could get on the phone at 3 o'clock in the morning. It sounds crazy to say that now, but that experience and having walked through the trajectory of rural medicine during that time really sharpens where I can see the value around provider-provider telemedicine. Next slide. And I don't have any information to disclose. Next slide. So over the past 12 years, we've implemented 12 different service lines around provider-to-provider telemedicine. And you know, what I don't have included here is the fact that we participate in the ECHO programs through the University of Washington School of Medicine and the University of Idaho. We do telepharmacy, we do teleradiology, and retinal scans that are done through telemedicine. But I focused really on these bigger elements of these service lines. And you can see some of the ones in blue weren't really particularly successful implementations. We've learned a lot in this journey. You know, interestingly, there's these 12 programs come across 7 different hardware platforms to deliver the care, and 10 different health systems or entities are involved in delivering those 12. So it's a bit dispersed, but it's certainly part of the initial experience. Today, I was just going to walk you through 2 of those areas, the telepsychiatry, the adult telepsychiatry program that we have, and also the telehospitalist, and then the most current instance of that, which is the tele-ICU experience during the COVID pandemic. Next slide. And we really believe that that telemedicine, provider-to-provider telemedicine, in our experience, we've seen improved clinical care. We see it reducing the financial burden to our rural population. You know, if I tell a patient that they're going to see a specialist in Spokane or Coeur d'Alene, that's a 3-hour drive each way for maybe a 20 or 40-minute appointment, and they drive back, and that's expense and lost wages. But most importantly, that's a huge barrier for our community, and it really ends up being care that's not delivered because the patients vote with their feet and don't go. So this is really part of the opportunity, and it's hard to measure that. We also have seen the creation of healthcare value by reducing healthcare costs. I'll talk about that in just a few minutes. And then also, you know, just improving quality and reducing those costs. We also believe that when done properly, we can actually help promote the sustainability of rural hospitals, which is really, as was outlined by one of the speakers yesterday, it's really a critical moment in sustainability of rural healthcare is the health of these rural hospitals. I've seen personally the impact on reducing primary care burnout in rural environments. And since I'm the physician that does provider recruitment, I can tell you that it enters into the conversation in recruitment. Next slide, please. And I'm just going to walk you through our neighborhood here in North Central Idaho and why some of the factors that really influence the value of provider-to-provider telemedicine. So next slide, please. And this just really shows in map Idaho and about population density. And the map on the left, the dark olive green, really shows those counties that are frontier level of population density, less than 6 individuals per square mile. The upper part there, Clearwater, Idaho, and Lewis counties are the counties that we serve. But you can see there's a lot in Idaho of frontier communities. And on the right, it just reflects the same thing in terms of population density. what you can't really see is the topography of the ground and the bad weather and all the other things that we contend with in delivering care. So it really makes it quite challenging and a ripe area for implementation of telemedicine. Next slide, please. This just shows physician density. On the left side is just overall physician density by state, and primary care density on the right. And the big red arrow shows where we are in Idaho. Not an enviable position, particularly because we know that primary care density and contact with specialty physicians do impact mortality. And as was mentioned yesterday, and I think you're all aware, there is a wide disparity in mortality rates between rural and urban communities, and that disparity is in fact widening over time. What you can't see, because probably the print's too small, but all those states that are really in that lower triangle where they drop away from the median tend to be rural states or states with a significant rural component. So I think it shows the point of where telemedicine, provider-to-provider telemedicine can have an impact in rural communities. Next slide. This also is, a map showing critical care, distance to critical care services in the United States. The dark turquoise is a high distance, and you can see in north central Idaho, where I live, it's quite a ways to critical care services. You can see the same, it's really the Intermountain West, Alaska, and the far western portion of the Midwest. And that really matters. I can tell you right now, I feel this very acutely in our system during COVID. Currently, for about the past month, the state of Idaho has been at crisis standard of care due to lack of critical care services and hospital capacity. And some days we've called as many as 48 ICUs throughout the Pacific Northwest and beyond to transfer critically ill patients. And sometimes we've gone all the way through those 48 hospitals, and the answer remains no, and we're put on wait lists. So having telemedicine to provide critical care services, even if they're interim stopgap measures to take care of those patients, is really essential. And, COVID really brought that to the forefront, but it was developing for a long time. So this is a very important point for rural America, particularly in the part of the country where we are. Next slide, please. This is just also showing like why provider to patient telehealth is nearly impossible in our part of Idaho. It's a little bit hard to follow, but the dark red in the Idaho state map there, those are counties where you could do provider to patient telemedicine, just the dark red, and there's very few communities, as you can see. I thought maybe a more telling graphic is the DVD Netflix envelope, and that's how I personally get my movies. So, I don't have the bandwidth, even living in this community, to download the movies. So that may be a different kind of graphic, but it shows the importance of that provider-to-provider telemedicine occurs in our clinics and places where we have better bandwidth. Next slide, please. And this is just really a reminder of that contact with specialty physicians does have an impact in mortality. We're not just making this up, this matters, and getting those services to those in rural and frontier communities really matters. So next slide. Well, I'll take you through our first example, and this is one of our oldest service lines that we have, which is the adult outpatient telepsychiatry program. We implemented this in 2009, and really 80% of the patients that became enrolled in this program had never had any formal psychiatric care previously. I served as their psychiatrist along with my colleagues. It wasn't something that I think any of us, the patients and ourselves, were happy about, but we were doing the best that we could. But we knew that we could do better for these patients. Next slide. This just shows the type of diagnoses. These patients really have major mental illness. The anxiety and depression, really, this isn't your garden variety depression or anxiety. This is refractory depression, really not responding to standard care. and then also patients with other major mental illnesses. Next slide. And what we did, certainly this isn't a robust study, but just within our system, we wondered, are we really having an impact for these patients? We felt that we were. We looked at their experience in our system, their utilization 2 years before implementation and entry into the program, and 2 years in the program. And what we saw, not too surprisingly, the emergency department visits for patients dropped substantially. A little bit more of a surprise, the all-cause hospitalization rates dropped, and primary care utilization also dropped, probably because a lot of that primary care was a proxy for the issues with mental illness. And really, we talk about the widening mortality gaps in rural communities, and a lot of that is driven by deaths of despair and suicide, substance abuse, and that's why successful implementation of telepsychiatry and other behavioral services is really critical to helping these rural populations. Next slide, please. We looked at the cost in our system around those 3 pillars of care, and actually saw the cost, the actual expenses for those patients within our system dropped to 40% of the pre-participation levels. So we believe, this is where the value creation is for the payers, and it also helps rural hospitals in the transition to some of the alternate payment models that are probably going to be necessary for sustainability. Next slide. A second example is really 2 different implementations. The first one is Telehospitalist program, which we had for several years. The entity that was providing that service actually was bought out by another company, and we're told they couldn't provide the service. So it went away, and more recently, a very similar instance of that, we've been fortunate enough to implement telecritical care service through the NETSIN program, initially through the Department of Defense. But I'll talk about both programs sort of blended. Next slide. And really, the idea with the telehospitalist or tele-ICU is just, the primary care physician in the rural environment or a family have some anxiety around the complexity of care, and particularly if the family may be wondering, should my loved one be here? The patient's wondering, do I need to be transferred as well? And we just initiate a consult to bring in that specialty consultation to either assure us that the care is right, or to make modifications to that care, or if necessary, transfer those patients. And what we ended up seeing was a reduction in critical access hospital to tertiary center transfers. And, it helped reduce some of the waste and expense, and I'll talk about that in the next few slides. And when that care actually did require transfer, it was a safer transition because the receiving hospitalist was more involved in the care prior to transfer. And so we had a more of a stable trajectory of care when that occurred. We also saw enhanced revenue to critical access hospitals, which I can't emphasize how important that is, working in a critical access hospital. And also for patients, this really had a significant meaning, and it reduced their individual costs. And I'll talk about that in a moment as well. Next slide. And again, just to touch on the financial jeopardy of rural hospitals, the critical access hospitals are the backbone of rural healthcare systems. They certainly are the nodes that anchor all the care that we give through the dispersed area that we provide services in north central Idaho, and almost all of them have some risk financially. In Idaho alone, according to the Idaho Hospital Association in 2019, so even pre-pandemic, 80% of Idaho's critical access hospitals were operating in a negative margin, which is a scary thing. And we're often the largest employer in the community, or one of them, so the impact, if we are to fail, is more than just even the healthcare impact. It just is a cascade of events. Telehospitalist programs, when done appropriately, can keep some patients in those communities, which helps the families, and it also helps the hospitals. Next line, or next slide, please. This is just some of our Medicare ACO data from 2017. I looked at, this is individual providers, and you can see the big red circle by far above anything else. Air ambulance service, which it tends to be how most of these patients move from our hospital to others, given the topography around here, is by far the most expensive provider. And this is an opportunity with payers to partner to reduce some of these transfers. Next slide. This is just an example looking at our 2020 hospital data at one of our critical access hospitals. I know that some interesting things happened in 2020, but I think it illustrates the point. We had 85 patients who were admitted to the critical access hospital. So these were patients that at least a priori were felt to be appropriate. And of those, 85 of those were subsequently then transferred, who had been admitted. And of those that were transferred, about 14% on chart review were discharged from the tertiary hospital under 4 days and didn't have a ICU admission or a procedure of care. So these are patients that arguably there's an opportunity to keep locally. It would be 48 additional hospital days locally, 144,000, which may not seem like a lot to those of you in bigger centers, but really in a rural critical access hospital, it's about 0.5% of our margin. And on a good year for a critical access hospital, a 2% margin is a wonderful year. And so 0.5% is meaningful, and that contributes to the survivability of these hospitals. Also in value-based care, just avoidance of that air medical transport shows that it's about a $27 per member per month savings. And to the patients, that 4 days is about $1,000, not counting lost wages. So that's a big amount for the patients we serve. Next slide. So anyway, just wrapping up some of the ingredients that we see through our experience implementing is that, first of all, both the consulting and rural providers need to understand the why of how this is creating value. Otherwise, it won't be successful. That's why some of those service lines closed. We also need to have technology platforms that really match what is needed, that there are adequate but not overly complex. We also need to have a delivery model that's financially sustainable, both for the consulting providers and systems, as well as those in the rural environments. And also need to lower the friction for the consultant to be able to view the necessary images and data to do a consult. And this was touched on yesterday. There needs to be a mutual understanding of the cultures, of the two medical cultures, and how we can make those work together. Next slide, please. And just the recommendations are that we need to identify the areas where we can leverage the most value. There's a lot of areas that we can study in provider-to-provider telemedicine in rural environments, but there are some areas that have particularly high value to patients and to creation of value in rural healthcare. And that answer might be different for rural Mississippi than it is for rural Idaho because of some of the system constraints. And we also need to know what the components are in those elements that really drive success. What is it that really makes it a successful implementation, and have some studies around what were the elements that made a difference. Also, I think that it's particularly important in the rural communities to look at telepsychiatry and behavioral health because of those deaths of despair. This is a huge area of widening disparity that we need to address, and so it needs particular attention. We also, as I mentioned, need a financial structure and understand how those financial structures really can make telemedicine be most successful. And I think that needs to be very holistic, looking at the impact to the community and not just individual payments and what happens within the walls of hospitals and clinics. It needs to be looking at the overall sustainability in the communities and also how it can support alternate payment models. And last of all, just as I mentioned, we have 12 different service lines over 7 different hardware platforms. This feels like it did early in EMR implementation where we had all these EMRs that didn't talk to one another. I think there needs to be some work on having some standardization of platforms so we're not having to duplicate that. With that, I thank you for your attention, and I'll look forward to the discussion and comments as well. Next slide is just my closing slide. So thank you.
Great. Thank you so much, Dr. McGrath. Your presentation really brought in an important perspective that we haven't heard yet in this workshop. So thank you for that. Okay, so we will now hear from Dr. Mei-Hua Kwong, our fourth and final speaker under key question 2. She will present on the outcomes of provider-to-provider telehealth relevance for private and public payers. Okay, Dr. Kwong, go right ahead. Thank you for joining us.
Thank you for having me, and good morning or good afternoon, depending on where you are. Next slide, please. Before I begin, I always have to start off with some disclaimers and disclosures. Know that any information provided in today's talk is not to be regarded as legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you do want a formal legal opinion. And if I happen to mention a company or show a picture of a product, know that neither I nor CCHP has any relevant financial interest, arrangement, affiliation, or relationship with such an organization. And otherwise, I have nothing else to disclose. Next slide. So for those who are not familiar with the Center for Connected Health Policy, we were actually established in 2009 as a California telehealth policy organization as a program underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Research Center became available in 2012 through a grant from HRSA. CCHP applied for that, we received it, and we've been serving in that capacity ever since. And what that means is we do have federal funding to provide technical assistance on telehealth policy questions. We help a range of people from anywhere from the White House and congressional members to state policymakers and legislators to health systems, health plans, providers. And increasingly what we've seen and what people who have reached out to CCHP, especially during the pandemic, have been patients directly who have had questions around telehealth. We also work with a variety of other funders and partners on the state and federal levels on more focused projects related to telehealth or connected health. And we act as an administrator for the National Consortium of Telehealth Resource Centers, which is an affiliation of the 14 telehealth resource centers underneath the same grant program as CCHP with HRSA. And we are convener for a group in California called the California Telehealth Policy Coalition, which is a coalition of over 100 statewide and national groups who are interested in advancing telehealth policy in the state of California. Next slide. So I've been asked to talk about the impacts and outcomes for both private and commercial or public payers regarding telehealth and the provider-to-provider models. Now, to understand the existing telehealth policies that are out there as they relate to provider-provider telehealth models, there's really sort of 3 main categories or 3 models that are focused on. You have your echo-like models, which is where a provider presents a case to a panel of specialists, and it's usually done through the live video or the synchronous modality of telehealth. Then you have store and forward, which is the capture of information that's sent to a provider, usually a specialist, to evaluate and provide feedback to the other provider, who typically is a primary care provider. And it's not done in real time. It's capture of information, you're storing it and you're forwarding it, and it's called store and forward. And it's usually signified a lot of times when you're talking about reimbursement and billing by the GQ modifier labeling it that it happened asynchronously. And then you have e-consult, which is transfer of information of the patient's condition to another provider, again, usually a specialist from a primary care provider. So a lot of times it's asynchronous, though it can be done via asynchronous, or can be done synchronously via live video. But it is at its sort of own separate category from like store and forward, and it has like very specific codes in which you like signify that you use these console. Now, this is typically, these are the 3 models, the provider-to-provider models that you see in telehealth reimbursement and coverage. And this is where most of the policy is built up around that. And it's not other parts of policy, such as like licensing or privacy, where you see these particularly referenced. It's usually around those reimbursement policies, and where you see actually sort of the barriers or the limitations of why these models have not been utilized more widely to this point. Next slide. Before we begin, I have to make sure that you understand that there are two separate buckets or two distinctions that need to be made in policy when you're talking about provider-to-provider models. There's a telehealth category, and there's a category called communications technology-based services. And what happened was a few years ago, CMS, when they were updating their Medicare policies, created this category called communications technology-based services, which basically is a set of services that utilize telehealth technologies, but in CMS's eyes, it does not equate to telehealth. Telehealth in CMS's eyes is a one-to-one replacement for an in-person service or a service that you would typically receive if you went and saw your provider in person. So for example, I go and see my physician for an office consultation. I can do that over telehealth. That's one-to-one replacement. Communications technology-based services are those services that we typically don't receive in person, but for because the technology has advanced to like such a point, they are able to provide these services. So there's not a one-to-one replacement. They both utilize telehealth technologies to deliver those services, but they may not be regarded as telehealth. The reason I'm spending some time on this is because definitely for Medicare, and sometimes when you go to the states, and commercial payers, they may also have created these two categories, and the policies are different for both categories and how they handle that particular service and how they cover it. They label it communications technology-based services. It has its own sort of separate policies, own different rates, and like how they reimburse it, what they will cover, etc. And telehealth is the same thing, separate policies around rates and reimbursement and what they would cover. And when you're talking about provider-to-provider services, they can fall into either category. So you have to like really take a look at what jurisdiction you're operating in and sort of what payer you're trying to receive reimbursement from to understand like how they're going to approach that provider-to-provider interaction. Next slide. So the barriers that typically happen when you're talking about provider-to-provider interactions underneath telehealth policies are usually related to the reimbursement policies. There is nothing in federal law or in state laws that prohibits a provider-to-provider interaction over telehealth. There may be other policies that impact it in some way and like how you do it, like maybe licensure laws, but for the most part, whether it is going to happen, it's really around those reimbursement policies. Is it covered under a payer's policies and will you get paid for it? So that's typically where the barriers are most present. Yes, there are other barriers such as like licensing that may have like impact, perhaps, you know, how you decide if like there is, you know, patient-provider relationship developed between like the consulting provider and the patient. But for the most part, it's really around those reimbursement policies that exist right now that are specific to provider-provider interactions that create the sort of more complications and barriers and challenges. Next slide. So first off, Medicare, which is the federal policy there. What you see as far as existing policies that relate to provider-to-provider interactions are around store and forward and e-consult. So store and forward is allowed underneath the Medicare program if you are a telehealth demonstration project in Hawaii and Alaska, and that is it. That is the only sort of store and forward specific to telehealth policy that they will allow, that they're able to allow, and that's statutorily required. That's what's in federal law. The other thing that they will allow is, and they will cover, is e-consult, but again, they have it underneath that category of communications technology-based services. So in their eyes, e-consult is not regarded as telehealth, though they have their own policies surrounding it. It's not a direct replacement for an in-person services, and they have specific codes with specific definitions of like what the service is that they will cover and reimburse for. So this is the policies that they have around provider-provider around what exists in Medicare. Next slide. On the state level for Medicaid, what we see for fee-for-service as far as provider-provider interactions, it's usually around store and forward, which only about 22 states, so less than half the jurisdictions allow for it. E-consult, some states do reimburse for e-consults in 17 states. And then ECHO, you may see more in managed care. It's not necessarily in the Medicaid fee-for-service side of things where it's covered, but you may see it more in managed care. For example, New Mexico actually probably has the most robust policy on the state level around ECHO. Next slide. These are the states that cover e-consult as of February of, actually that should be this year. As of February of this year, these are the states that have some sort of e-consult code that they would reimburse for. This has probably shifted a little bit since like we took this data. And you have to understand that it may not be as robust as what Medicare does. So some states may have selected one e-consult code to cover, or they may have like selected all the ones that Medicare has. And you may also have to realize that e-consult here, the states, again, their approach may be different than what Medicare did. They may not necessarily have separated out into that communications technology-based services category. They may have wrapped it into or brought it underneath the umbrella of their telehealth policies. For example, California has done that. California only reimburses for one e-consult code of those codes that I showed on an earlier slide for Medicare, and they have it underneath their telehealth policies, actually underneath Store and Forward, rather than having it separated out. But other states do have it separated out from their telehealth policies. Next slide. For private payers, so private payers, there's less defined policies around provider to provider interaction. So for the most part, what states have for policies around telehealth for private payers are private payer reimbursement laws or coverage laws. And they range from anywhere from a state saying, health plan, you can cover telehealth if you want to, all the way to, you know, a state dictating or mandating that health plan, you must cover telehealth delivered services the same way you would have in person. And by the way, you will pay the provider the same amount that you had in person. And then all the other states kind of fall between those two extremes. Again, there is nothing in state laws that we've seen that prohibits the provider interaction. It's more of a question of, will it be covered and reimbursed underneath a payer's policies? And again, there's nothing that prohibits that. So private payers could make that decision without being told by the state that they have to do that. Next slide. So reimbursement, Medicaid reimbursement for Store and Forward, it's usually very limited. It's usually specified as to what it will be, usually for dermatology, ophthalmology, and dentistry. And there may be limitations on the type of providers who could provide or get reimbursed for delivering services via Store and Forward. For example, community health centers like FQHCs and RHCs might be excluded from those policies if there is a reimbursement policies for Store and Forward services. An example of some of the more expansive policies in California currently, they allow the provider to choose whether to deliver services via live video and Store and Forward, as long as certain conditions are met. But for the most part, most of the states, what we see in their Medicaid policies for Store and Forward, it's like usually limited to very specific services or very specific specialties. Next slide. Medicaid reimbursement for e-consult, again, as I mentioned earlier, may be treated to how similarly it's treated in Medicare, in that it is separated out as communications technology-based services, or it may be wrapped underneath like their telehealth services. Again, it just really varies depending on what state you are in. So if you're a provider that operates in multiple states, you can have widely varying policies around your provider to provider policies there, and what will be covered and what will be reimbursed. Next slide. For managed care, so Medicaid managed care, for a lot of the managed care programs, they're actually provided a lot more flexibility in how they utilize technologies. The fee-for-service policies, which what I just gone over a little bit earlier, are just sort of like the level, the foundation or the base of like the minimum of what they're supposed to cover. But plans can actually do more. There's usually not a prohibition from them doing more. And some plans may explore that. For example, some plans may do more echo models or have echo pilots that they do for their enrollees, even though it's not reflected in like the Medicaid fee-for-service side of things. But for a lot of times, plans also really closely adhere to like what the fee-for-service policies are regarding telehealth too. Next slide. So some recommendations, we were asked to give some policy recommendations to consider, and this is where I'm taking off my federal funding hat. So this is not, what I'm saying next does not come underneath, does not reflect the views of HRSA, does not come underneath the HRSA funding. It is strictly just May Kwong separated from my federal or other grant funding. So some of the recommendations I have to consider is like when you're talking about definitions here, we talked about like how the terminology is sometimes very important, and also the labels that are put on things. I would say if you're doing like a specific definitions, to stay away from very specific definitions, especially when you use language like, you know, real time or services directly provided to patients. That would really limit like your provider to provider interaction. So if you say real time, it like limits, like you can't do e-consult or Stern 4. If you say services directly to patients, that really eliminates provider to provider interaction for those policy coverage. Also allow for all modalities. Real life telehealth is a tool, it's not a service, and the modality is just a different way of like providing the services. Don't limit it to just one modality. That way you eliminate all the other tools that a provider could use to provide services. If you say it's going to only be synchronous, then when you're eliminating like e-consult, for the most part, a lot of e-consult and store and forward. And allow for more providers to utilize telehealth. A lot of existing telehealth policies limit the type of providers who can provide services, usually to physicians or nurses, and they eliminate a lot of the allied health professionals like PTs and OTs from providing services. So I recommend not having that very restrictive specific provider list. And also be aware of continuity of care. There's been a lot of concerns about policy from policymakers and also from healthcare providers of, if you're receiving services from different providers, how are they communicating with each other to ensure that there's that relay of information and that continuity of care. So be mindful of like how information is really relayed between providers, especially when you're talking about a provider to provider interaction. Next slide. And there's some information about CCHP. Our website, we do track all of the state laws and policies and regulations related to telehealth. So that is on our state. It's broken down on our website. It's broken down by state. So you can just go to our website if you're interested in a particular state or two. We also have a newsletter that you can subscribe to. And next slide, I think it's just contact information. And I thank you for this time.
Thank you, Dr. Kwan, for your presentation. That was a great addition to this session. So we now invite all key question 2 presenters to join the discussion and the Q&A session moderated by Dr. Wakefield. Just a reminder to our attendees, thanks for sending your questions through the Q&A pod. We'll continue to receive them throughout this session. And Dr. Wakefield, we're running a little bit late, but just a little, so let's take the discussion session until about 1:10. If
Sure.
you've got questions.
Sure,
Thank you.
not a problem at all. Of course. And what an incredibly rich set of information from the panelists. Thank you so much. And also, Annette, thank you for setting us up at the very beginning. This was just a terrific and informative set of remarks. So with that in mind, I want to make sure that folks know from the audience that they can certainly ask questions by adding them into the Q&A in the lower right-hand side of your screen. But having said that, we will start with any questions or comments from the independent panel that, and so my colleagues. In particular, I want to begin with, for this particular question, with Velma and Joanne, as Velma and Joanne are going to be doing some of the follow-up work in related to the effectiveness of provider-to-provider communication. So Velma, Joanne, if either one of you would like to step in with a question or comment, please do that now. And then I'm going to turn to the broader set of panelists, and then we'll take any questions from the audience.
Thank you. And thanks to the wonderful speakers. As my colleague Mary mentioned, it's just been an absolutely incredibly rich discussion. So one of the questions that I had was for the speaker that talked about, and I tried to put your names above it, but you spoke about Dr. Zeppler. You spoke about using asthma as a model to begin to examine issues of telehealth. And I just wondered, in thinking about the other speakers who noted limited evidence of telehealth effectiveness and patient outcomes, particularly around a lot of the chronic diseases. And I'm just wondering your thoughts about the application of this model for other ways of engaging provider to facilitate positive patient outcome. Is this a model that works specifically for asthma, in other words? Or do you see relevance for applying this across the board when you're looking at chronic and acute diseases?
Yeah, my approach in the Denver area, our program started out with the Denver public schools, and it's been sustained mostly because of the drive of our nurse manager, Donna Shocks, and she developed a chronic care team. And so there's things like diabetes, asthma, other chronic diseases. And it's been amazing what they've accomplished in developing dashboards. So it's been a collaborative kind of back and forth. So I see it as managing any chronic disease. If we just kind of set up the structure, some of the things that we found was the school nurses were apprehensive about bothering providers, or they couldn't reach them by phone. And I mentioned in the question and answer, we still rely on faxes, and the high tech people go into convulsions when I mention that. They think the fax machine is in the Smithsonian, but it's, something you can store confidentiality, but you have to make sure it gets to the right source. So yes, to answer your question, I see this model. Once you set up the bridges, you can extend on that.
What I really like about your response is, the speakers yesterday, some of them talked about expanding the network such that we begin to look at multiple groups of members being teams to help with the facilitation of telehealth. And that's what you're saying. But it also seems that it's coming from more of a wider community base versus the providers themselves.
Yes.
Yes.
Yes, definitely. That's a good point that you raise. There's the socio ecological frameworks. And when we started out, our focus was on the patient. But as we worked with the schools and then now in the rural communities, the focus is really on the community and kind of setting that up because there's multiple school districts. There's less providers, but the school districts are spread out, smaller number of students in the school. So we have to kind of look at it kind of in a different focus in setting up these, what we call implementation teams. And they become kind of the bridges that connect.
Thank you. And I have one more question, if it's okay, Mary. And so for Dr. McGrath, very wonderful study that really demonstrated a lot of positive outcomes as well from the use of telepsychiatry. I'd like for you to talk a bit more about, because you have wonderful outcomes. I'd like for you to talk a bit more about your thoughts with regard to the heavy reliance on telehealth, as other speakers talk about the preference for in-person service. What do you attribute the provider telehealth usage on positive patient outcomes in your work? What's key? Because other speakers say patients like being in person. You're showing that telehealth is working and that there is an increased uptake of this innovation in your patients. What do you attribute that to? And what's the role of the provider in that process of facilitating this?
Yeah, and as I understand your question, it was why did the patients accept this service? And I have to say, when we were rolling this program out, I thought, oh my gosh, when I saw some of the patients that were queued up for this, I thought that our telemedicine equipment we're gonna be thrown out the window pretty quickly, but it didn't happen. It never happened to my knowledge. And your question is excellent. I think, as best as I can discern, what really made a difference was having the right people involved. And by people, I don't necessarily mean the psychiatrists, but the psychiatrists were really key. They had to be engaged and understanding, this strange domain that some of these patients have delusions about messages through the TV, and here we are providing care through, a platform like that. But they understood that. So having the psychiatrists understood it, but I think that our local the medical assistant that really piloted the program in our community, there were a couple of them. Their engagement helped the patients to trust this. And I saw people that really just even doing in-person care with them was profoundly difficult, and it seemed to go very well. And doing the telemedicine, and I think it was really the local staff, people from the community that set it up. I've asked myself that question many times, and that's the answer that we mostly find. They would call the patients the day before, make sure they had transportation, and they really, I think the patients felt that they were aligned with their best interests, and that was it. That's the best answer I can give you.
I have more questions, but I'll have my esteemed colleague Joanne ask questions as well.
Thanks, Velma. I have a question for Dr. Kwong and a question for Dr. McGrath. So Dr. Kwong first, we heard from somebody yesterday that there's a lot of provider-to-provider telehealth or communication-based activities or that are not acknowledged, not billed for. People don't believe that the reimbursement is worth the effort to even submit a bill. What do you think about that statement, number one? And number two, do you think there's a reimbursement price point at which somebody will go through the extra effort to actually bill for the provider-to-provider service?
So right now, for your first question, yes, it's true. There are probably a lot of actually clinics that are not billing for their provider-provider interaction, but they see it as something that is necessary for their patients for treatment, so they're willing to basically eat the cost on that. And that is because the reimbursement for those provider-provider interactions, I'm probably guessing a lot of them are doing it via e-consult, is very low. It's probably like in the $40, $50 range. So it's really, unless you have the volume for it, it's probably not worth your time to do all that work. And if you're only doing it for like a couple of patients, you probably just eat the cost on that. As far as the price point, part of the problem I think has been, and strangely, actually Medicare is a little bit forward thinking on this, is that the cost, reimbursement is usually geared towards the specialist receiving reimbursement, whereas the provider who is like engaging with the specialist, usually a primary care provider, their cost is usually not covered in that interaction. And so they're probably the ones who are not going through the whole billing process, where maybe the specialist more likely is. So where the problem kind of lies a lot of times is like the policies don't actually really cover those primary care specialist times. So they are eating the costs there because simply the policies don't exist for that. So that's probably where some of the policies need to shift, is to cover more of that initial engaging provider, who may not, again, usually is a primary care provider, but may not necessarily be a primary care provider who's in that consultation.
Great, thank you. And Dr. McGrath, when we looked at the literature, I was shocked that there wasn't more on tele-ICU. I'm at Dartmouth-Hitchcock, and we're the most rural academic medical center in the country, so we do a lot of telehealth. It was striking, though, that the evidence in ICU and EDU care was really not documented in rural health. I was surprised how few studies there are. So if we were going to design a study that demonstrated the value, what do you think the elements should be of that that would really reflect the importance of tele-ICU and tele-ED to critical access hospitals?
Yeah, I think one of the challenges is that there's disparity of the service that's provided even under that umbrella. For instance, I actually, just as recent as a week ago, we had a critically ill patient in the emergency department and engaged the telecritical care specialist on that. And that patient spent about 10 hours in the emergency department before we were able to effectively get a transfer for that patient. And so there's that model, and then there's that model of, oh, we're keeping this patient and we're going to have our rural nurses doing critical care and all that. And I think you almost have to separate that question, if that makes sense. So what was the trajectory of that patient that was transferred like last week? And was their ICU stay less? Was their time on a ventilator less? Things like that. That first 6 hours of critical care is so important. And I think looking at that box of what do we do in that first, a person comes in septic shock, what happens in those first 3 hours, and how critical care can impact that versus we've got a patient on a ventilator at a rural critical access hospital, and what is that outcome there? So I think it's important to separate those two boxes, because I think you might see a different answer. And then I think just looking at the broader impact, as we were talking about more holistically, the impact on the community and also in the cost in particularly alternative payment models. I mean, I'm amazed at how expensive air medical transport is, and just I think the economics of it also need to be included. So I don't know if I answer that question, but does that make sense, sort of my thoughts on that?
It does. And let me just ask a follow-up question on the benefits to the providers. How would you design that study? I think of things like retention or satisfaction. What do you think you would measure for a rural health care provider that would actually be able to measure the benefit of a hospital or community investing in telehealth services to make their professional life a little bit easier?
Yeah, that's a great question. One way that we've measured it around telepsychiatry, but it was really hard to separate that out from all the background noise, was looking at provider well-being scores, which we measure on a quarterly basis and track. And it was hard to see that signal because we're small. And I think over a larger system, maybe you would. But their burnout scores, how overloaded, and there's some specific questions I think that could look at that, and their likeliness to feel, or do they feel supported by their system, and things like that. Those are the things that anecdotally my partners come back to me and say, they did tell me that when we implemented telepsychiatry, that they thought that, when I think of a couple of partners that told me they thought that they might practice an additional 10 years because of that, just having that that burden taken away from them, and maybe looking at things like that. It's but I think burnout, particularly in rural environments, is for primary care is a good index to look at.
Great, thank you.
This is Annette. Can I chime in on that question for 30 seconds? And if I can, I would just say that the studies of remote ICUs that have been done that haven't been in rural areas have been pretty well done. So we have sort of a model. The challenge in doing it in rural areas, and I think, Joanne, you're in an unusual situation because most rural areas don't have strong academic medical centers or affiliations. And a lot of the places that are trying to do this are like his, which are relatively small. And one of the challenges is the inequities in research capacity. So, as pointed out, he's got a relatively small number, and to really get sort of the research chops you would want, might need to combine multiple centers, and we don't have good ways of doing that or good ways of helping multiple smaller places collaborate to have the numbers for better research. Does that make sense?
Yeah, that's a good point. Thank you.
May I have a follow-up as well, Mary, if it's okay?
Of course, Velma, thanks.
Dr. Trotta's comment reminded me also of your saying that one of the reasons why we may know less about provider to provider telehealth delivery to patient outcome has to do with ways in which we're not measuring it, or they're not measuring it, or the measurement is inconsistent. And in light of what Joanne just said, I'm wondering how might we leverage the NCATS CTSAs that are around the country as we're looking at the role that academic partners may play in assisting these isolated rural community hospitals in data collection. So that was one question. And then in light of that, the question is, do you think that we know more about how telehealth education and mentoring is assisting the providers because it's designed to assist the providers rather than facilitate skills to improve patient outcomes? I'm just wondering, are we measuring that in fact, or is it truly for enhancing skills, knowledge, attitudes among providers that will then translate to improve healthcare?
I don't know, Mary, who wants to
Questions.
take it, or Mary,
Sure.
do you want to decide who takes it, or?
No, jump in, Annette, and then we'll hear from others. Go right ahead. Thanks.
I'll do it quickly in reverse order. I think that ECHO and the other training programs believe that their mission includes improving patient outcomes. I think that in the causal chain, you do that by improving provider knowledge and skills. And I think that it's easier and cheaper to measure things that are closer to the intervention than things that are further out. And that's always a question and an issue. But I think most people would argue, well, on the one hand, it is good to have happy providers. We wouldn't be okay with happy providers if care doesn't improve as well, or at least be as good as. So that's the first one. The thing about outcomes is tricky, and it's a big issue because telehealth covers so many different things, and you need to think about the right outcome. And sometimes maybe we don't measure the right outcome. The best example I have from a prior review is the telestroke. A lot of the telestroke literature finds telehealth sort of as good as in terms of time to treatment and mortality. But in talking to stroke experts, one of the problems is they tend to focus on inpatient mortality and don't necessarily look at function maybe 30 or 60 days post-stroke. And one of the biggest costs, both for patients and the system, is for disability caused by stroke. And TPA and getting patients treatment faster, the stroke people who are clinical tell me, is less likely to keep somebody from who had a major stroke from dying. The people who are going to die are usually pretty severe, but may actually have a huge impact on how well they function post-stroke, the people who survive. And so that might be a situation where we're not actually measuring the thing that would show the biggest return on investment.
Thanks, Annette. That's really helpful. And do any of the other panelists have a comment on that question from Velma?
As a speaker, I could answer some of the question because I've gotten now very heavily into dissemination, implementation, research. And the program that I described, we're applying that. We're using a mixed methods aspect of assessing things. And I find the qualitative methodology is extremely important in terms of getting some insights, because you can, when you do surveys, less than 50% answer. And so applying a qualitative methodology with a prospective plan in terms of what do you want to get at and how do you want to frame that and how do you put it together, I think is more relevant, because you really get insights into the community and what the individual is thinking. And it really helps you move on to the next level, I think.
Mm-hmm. Thanks. Any other comments on that on that question, on the question from Velma? Velma or Joanne, do either of you still have any other questions you would like to pose before we turn to our other colleagues? Anything else from either of you?
I don't have a question, just a comment, and the word community keeps coming up, and we didn't find that in a lot of what we've been reading thus far. But you're bringing up the word community and collaboration among multiple entities.
I don't have
Yeah,
any more
I'd
questions.
say, like even in the Colorado area, and Dr. Kelly made comment on, or McGrath made comment on this, is that even in the communities where there's a city, you don't have to go too far to get into the rural community from that city. Denver's an example with Brighton. But, you know, there's kind of a perspective of patients of what's city and what's outside the city. And so you get these different dynamics that are important to consider.
Any other comments on that focus of community before we leave and invite other panelists to raise questions from others? Okay, let's go then to our colleagues. Thanks, Velma and Joanne, for helping us to kick off those questions. Really appreciate that. Are there other comments or observations from my colleagues on our independent panel that you might have for these individuals now?
Yeah, I have just a comment. Dr. McGrath brought up, I think, a good point on, you know, what they're seeing with the P2P providing benefit to the patient, such as a decrease in the cost of, you know, the travel and time away from work and whatnot. And he asked, you know, how do we measure that? Because I think that is important. Obviously, the payers are more interested in what it's going to cost them and whether they want to pay for that reimbursement. And but I would say we don't want to forget to look at how we better measure the benefit to the patient besides just clinical outcomes.
Thanks, Dr. Moser. Are there comments in response to Dr. Moser's observation?
Well, I would agree really strongly, and I sort of rolled past that really quickly just due to time constraint. But I can say just, you know, being in a small community and having that personal connection to these families, it's huge. And I think that, you know, it's challenging to measure that, but it's a real impact. And I hear about the financial strain, the sort of social strain that it also has. Just recently, you know, with us now being in such a dire situation in Idaho now, there was a state representative whose mother got transferred to Seattle for care. And she had to actually pay to have her mother, who had some degree of disability, to be transported back. And that was a $9,000 out-of-pocket cost for her. And, you know, we're not measuring those things, but it's huge.
Great observation, very helpful observation. Thank you for that too. Are there other questions or comments from the panelists? From my colleagues, the independent panel?
This is Jayashree Shankar Narayanan from University of Nebraska Medical Center. Lovely presentations by Drs. Zeppler, McGrath, and Dr. Wong. So thank you for your great insights. It's been wonderful to listen to your rich presentations. The question I have for Dr. McGrath is that one of the slides you mentioned that you all were able to make more money for the critical access hospitals by the telehealth program. So I was just wondering if you could elaborate a little bit more on the cost savings. That would be my first question for you.
Yeah, and it's really, you know, it's funny to frame it that way, and that sounds mercenary, but it's really about making these hospitals survive.
Yes.
So much of what I do, you know, is not medicine. It's trying to keep this hospital alive because I know the impact it would have on our community if it closed. And it's really just looking over the years at unnecessary transports and particularly having you know, some partners that may be more risk averse, that really what they just needed was some cognitive input on that patient. Yet the patient went by helicopter to somewhere remotely. Family had to go there, and yet that would be revenue. You know, really, it's the quadruple aim. I mean, to deliver that care for a better experience for that patient, to be near their family, but to keep that revenue that's really pretty easy revenue. These are people that didn't go to an ICU, they didn't need a procedure that wasn't available. and having that care close to home. And it also just, even though it seems like a small amount of revenue, to us it's the difference between, you know, keeping the lights on or not. And that was really a conservative illustration I did. I think, you know, if it was done really well, it could have an even bigger impact. And you know, and it drives the programs that we take out to our community. You know, we're not we're not living high on the hog. We're trying really to support our community, and it's a very mission based, as I think a lot of critical access hospitals are, and it supports the mission that we have. I don't know if I answered. I sort of editorialized more than answered, I think. Sorry.
That was very helpful to know, you know, like in terms of the savings, and that could help the critical access hospitals stay open and prevent closures. So I think an economic analysis would probably show a bigger impact rather than, you know, direct cost of analysis, you know, cost of, I would say, cost savings, which would probably be an underestimate, is what probably you're saying. So that was very helpful to know, Dr. McGrath. My next question is for Dr. Wong, and this is regarding the telehealth and the CBTS, the two different models of healthcare, I think, healthcare interventions. Can Dr. Wong hear me? Is she on?
Yes.
Okay. Thanks for your great presentation. Very informative about the different policies and different healthcare models. So my question to you is, you know, what are the differences between the telehealth and CBTS? What are the, in CBTS, what kind of, you know, services would you ask, you know, could you give some examples for CBTS? Because telehealth, we keep talking about them. We say tele-ICUs and tele-psychiatry. So I was just wondering, what would qualify for CBTS?
So the differences between the two sort of policies that exist for that, it's really kind of an artificial difference. And it was really started by CMS when they, a couple of years ago, when they were trying to reimburse for services which they were being delivered via telehealth, but they didn't have that in-person sort of replacement for it. So it's your remote patient monitoring, it's the provider to provider, a lot of the provider to provider consultation. That's why you see a lot of the models such as eConsult that are provider to provider listed underneath the communications technology based services. It's still utilizing telehealth technology. So the mechanics of it, the delivery of it, it is still telehealth. It's just almost an artificial way of like structuring the policy that was created. Now that was started by Medicare. Unfortunately, it's been duplicated sometimes on the Medicaid level, on the state level, where they do have like these separate policies. But then again, there are some states that don't separate it out and they simply have them underneath, you know, their regular telehealth policies. The example I gave was California. CMS clearly separates eConsult consultations, which they have very specific CPT codes for. So it's usually, the way they defined it is a provider to provider consultation that lasts for a defined period of time, like, you know, 5 to like 15 minutes is like one code, 15 minutes to like, you know, 30 minutes is like another code. But then for California, they actually pulled one of those and put it underneath their telehealth policy. So it is extremely confusing for depending on like what jurisdiction and what payer you're talking about and how they approach it. But as far as actually delivering services, it's still really all telehealth. It's just how the policy has been structured. But for the most part, what you're going to find underneath communications technology-based services policies probably are going to be those eConsult codes. And sometimes some store and forward, although for a large portion of the states, their store and forward policies are underneath the telehealth umbrella.
Okay, so what would you classify the telepharmacy, you know, scenario? Would that, it's considered, I don't know what is the status of that. It is being covered in certain states, I guess. Would you have some information on that?
Yeah, that really hasn't been drawn into the CTBS category. So they've been so TBS, what you usually find in there is like e-consult or remote patient monitoring. That sort of makes up the large part of it, and they've given it different labels such as, you know, remote therapeutic monitoring sometimes, but it's all remote patient monitoring. So the telepharmacy side of things, that actually predated the creation of the CTBS stuff. So a lot of that is actually underneath the telehealth policies for the different states. So they do have it underneath that umbrella as opposed to underneath the CTPS umbrellas.
Okay,
I
okay.
really hate to do this now, but I'm
Yeah.
going to have to call time if that's okay.
Thank you.
Jayashri, are you
Yeah.
good?
Yeah, I'm
Okay.
good. I'm good.
You're sure?
Thanks, Dr.
Okay,
Kwong,
great. We've gone over a little bit, but this is such a rich conversation, and I'm feel very badly that I actually am having to call time now. But many thanks to each of
Okay, welcome back, everyone. We're going to get started on the second half of day 2 of our workshop. Before we do, I just want to mention a quick reminder to all of our attendees. If you have questions, put them in the Q&A pod located in the lower right-hand corner of your screen. When asking a question, please mention the name of the speaker in your question, but send it to all panelists. I know it's a little confusing, but if you hit all panelists before hitting send, then we'll be able to, it'll make it easier for us to make sure it gets answered. So we will hear next from our keynote speaker for today, Dr. Kara James, and she will be presenting on applying an equity lens to telehealth utilization in rural communities. So Dr. James, welcome.
Thank you so much for having me. I'm really glad to be here and to talk to you today about applying an equity lens to telehealth utilization in rural communities. As a disclosure, if you go to the next slide, I do own some stock in Apple and Google and Microsoft, and in the past year I did receive an honorarium from Apple for a presentation. So on the next slide, just to tell you a little bit about where I am now. I'm at Grantmakers in Health, and we are an organization that works with health funders and philanthropy organizations, about 200 funding partners across the country, as well as corporate giving programs across a variety of areas, including rural health, to help achieve better health through better philanthropy. On the next slide. I'd like to spend some time today just kind of talking a little bit. I was asked to talk about some of the policies in terms of what we have for telehealth coverage, and then to think about implications for what it means for equity across rural communities, and talking about some of the services. So as I'm sure you all know, but we will just breeze through this quickly. You know, telehealth services began in Medicare with the Balanced Budget Act of 1997, and they began in 1999. They are guided sort of by the Social Security Act, Section 1834M. And you can see in terms of the allowable services that are covered through the Medicare program. On the next slide, there are location restrictions, and this was before COVID, where Medicare would pay telehealth for beneficiaries receiving services in an originating site that was a rural health professional shortage area, county, outside a metropolitan statistical area, or participating in a federal telemedicine demonstration. There were some exceptions, and you can see the eligible originating sites that were included in the telehealth program before the pandemic. On the next slide, you can see that even before the pandemic, there were efforts by CMS to expand access to telehealth. In the calendar year 2019 physician fee schedule rule, there finalized policies to expand access to virtual services, and those virtual check-ins, which were mentioned in one of the other presentations a little bit, as well as some of the remote evaluation of pre-reported patient information, or what we would call store and forward. There are also additional codes, so expanding the services for chronic care, remote physiologic monitoring, and interprofessional internet consultation. And then finalized in the payment for rural health clinics and federally qualified health clinics for communication technology-based services and remote evaluation services provided when there is no associated billable visits. And so that is one they were not previously allowed to be sort of distant sites. On the next slide, when we also talk a little bit more, go ahead to the next slide, please. We looked at telehealth utilization before COVID in a report to Congress and analyzed within Medicare the fee-for-service claims data and found that utilization, while it had increased, it still was actually very limited in the Medicare population. And you can see that in 2016, there was less than a percentage of Medicare fee-for-service beneficiaries were utilizing telehealth services. And if you think about, we have about 7 million rural Medicare beneficiaries. But there was significant growth in utilization, interestingly, among the oldest population, those beneficiaries age 85 and older, and psychotherapy was among the services most commonly furnished, as well as we saw high levels of beneficiaries utilizing telehealth services who had a mental health diagnosis. Not surprisingly, the states with the highest utilization also had large rural communities, and those obviously Texas, Iowa, California, Missouri, and Michigan. If you go to the next slide, what we also saw was that there were limited telehealth providers throughout the states. And so the lighter states reflect the number of Medicare providers that were less than 75, and in 12 states you had only 75 or fewer providers who were offering telehealth services to Medicare beneficiaries. And in the dark blue states, you had more than 200, which was 5 states. So nationally, we were looking at just over 5,000 Medicare providers offering telehealth services. That has clearly changed as a result of the pandemic. If you go to the next slide, when we look at Medicaid, obviously coverage varies by state. We do have 49 states in the District of Columbia that have formal definitions of telehealth, but as with everything, it varies across the state. All states do reimburse for live video, and you have more variability in coverage for store and forward and remote patient monitoring, as well as who is allowed to offer those services and where the patient must be when they are receiving them. There are 24 states that don't limit the location of the patient, and within that, 15 states do not restrict who is able to provide those services. So there's a lot more variability in terms of what we've seen. And then we've had the pandemic started, and if you go to the next slide, there obviously has been a lot of attention focused on increasing access to telehealth services throughout the pandemic. You can see some of the resources that have been provided, specifically focusing on some of the rural communities where we've had increase to provide services to patients at their homes and mobile locations, obviously a challenge with access to broadband and other internet, even within where broadband may be available. Resources to HRSA as well as USDA and the Indian Health Service to increase distance learning and telehealth across the board. So what has happened, if you go to the next slide, CMS has also made changes where they've added 144 telehealth services like ED visits and discharge day management through the end of the public health emergency. In December of last year, I finalized the inclusion of more than 60 services to the telehealth list that will extend beyond the pandemic. And also began a study of telehealth flexibilities, and also included licensed clinical social workers, clinical psychologists, physical therapists, and others who can provide that brief online assessment and management services, as well as the virtual check-ins and remote evaluation, and have also allowed for virtual direct supervision for 2021. So those were the changes that were finalized for this year. And then if you go to the next slide, what was just more recently proposed in Medicare telehealth is the extension of some telehealth services through 2023 to help evaluate whether they should be permanently added to the telehealth list. Also proposing to allow audio-only communication technology in mental health for providers with the ability to do both video, and are soliciting comments on potential use limits. And finally, also proposing to allow rural health clinics and FQHCs to receive payment for virtual mental health visits after the pandemic. So lots of changes have been made, and we all know there's been huge proliferation in the use of telehealth services. And just to talk a little bit about what that has looked like on the provider side, if you go to the next slide, these data come from a survey from MITRE Corporation in partnership with others of about 1,500, a little more than 1,500 providers. And as you can see, many of the providers responding to this survey started use of telehealth within the past 6 months, and a number of them 3 months or fewer. But you did have a portion who were using that beyond a year. And this was fielded in July and August of last year. There were fewer rural providers who were using asynchronous telehealth to either provide consultation to another provider or to receive consultation from another clinician. And if you go to the next slide, in terms of how providers have been using telehealth, you can see that fewer rural providers have been using things like Doximity or telehealth vendor or an EHR telehealth vendor. And why that's important, obviously, for HIPAA purposes and the privacy and security. So these other forms, Zoom, Skype, as well as Microsoft Teams, are less secure. And while we have waived the flexibility, provided flexibility on HIPAA in good faith during the public health emergency, it does raise questions about whether or not these providers will continue to offer those services in when the public health emergency ends. And again, you see fewer of those rural providers who are using those services. On the next slide, when we look at provider perceptions of patient outcomes for telehealth, and I think this is an interesting one, we do see that more rural providers disagree with the statement that telehealth has improved the health of their patients. And they are so thinking again about those long-term utilization of these services. On the next slide, when we think about patient safety, again, rural providers are a little more likely to disagree with the statement that telehealth has improved the safety of their patients as well. And if you go to the next slide, we know we have workforce shortages and challenges with providers and burnout. And this one is, I think, a little concerning when we see much larger numbers of rural providers who strongly disagree with the statement that telehealth has improved the satisfaction of their work. So we have some work to do. It'll be interesting to see what this number looked like before the pandemic for those who were using telehealth, and how this changes over time, as well as what this looks like and how it varies by provider type. So lots of things, food for thought, and things to think about in terms of how do we improve the experience for providers who are using telehealth services. And then on the next slide, one of the other pieces that I think is interesting when we think about, telehealth as a way to improve access to care. And here we see again larger portions of rural providers who disagree or strongly disagree that their patients have better access to care since they began using telehealth. Again, these are just impressions, not quite the full rigorous evaluation that we would want to look at, but it does signal some of the challenges that we have. On the next slide, we asked providers about their anticipated barriers to maintaining telehealth post-pandemic, and these were the top ones that rural providers listed. For both rural and urban providers and those in suburban areas, low reimbursement and technology challenges were number 1 and 2, hands down. There was little more variability between rural providers and urban providers in some of the other ones that were lower on the list. But you can see concerns about integration with EHR, integration with additional technologies, the cost of implementation and maintenance, as well as liability issues, the lack of technical support, and clinician dissatisfaction. I think it's also interesting to think about, practice size for some rural providers that may be small or solo practitioners. Where does that technical support come from, and the ability to help implement some of these challenges? So that's from all of that survey. From other work, if you go to the next slide, there have also been other barriers that have been lifted up for provider utilization of telehealth. We think about, again, that training issue, acceptance of technology, broadband, and other connectivity issues, the lack of providers sometimes at the other end to be able to help, as well as limited technology, licensure and credentialing, and poor reimbursement that is often cited. So that's some of what we have seen from, kind of the provider perspective. And when we think about what this means for health equity, if you go to the next slide, we have seen over the past year and a half, huge increase in the portion of people who are talking about health equity and focusing on health equity. But it's worth noting that we're not always talking about the same thing. So I wanted to kind of start with a definition of, the healthy people in terms of health equity being the attainment of the highest level of health for all people. And when we think about what that means, it really is sort of, from a measurement perspective, daily reducing and ultimately eliminating disparities in health and its determinants. And I think as we're thinking about equity in this context of provider to provider telehealth, it's also worth thinking about equity from the provider's perspective. And so if you go to the next slide, what does this mean? It doesn't mean we give everybody the same thing, but it means that we're giving people what they need to be able to achieve their highest level of health. And similarly, thinking about what providers need in different parts of rural communities and in different places where the challenges are not the same, giving them what they need to be able to participate into and thrive in the service of telehealth and other opportunities to improve the health outcomes for their patients. If you go to the next slide, just one way in which this kind of plays out in utilization of telehealth varies by region across the country. And when we think about the distribution of, for example, rural adults, you can see that overwhelmingly rural Blacks live in the South, and similarly high portions of rural Hispanics live in the South. And so when we think about, the role of Medicaid variability in terms of what's covered in telehealth and who's able to access it, it can have implications that lead to greater disparities for different populations when we look at the data at a national level. And so if you go to the next slide, some of the things to think about when we're looking at applying an equity lens to policy development and thinking about what it means for all policies, but also as we apply this to telehealth. What are the existing disparities in this area and the drivers of those disparities? When we think about telehealth, if we're looking at it from a race and ethnicity lens, we actually have seen that telehealth utilization among Medicare beneficiaries of color is, roughly speaking, proportionate to the population. We have less insight into Medicaid because we do not have really good race and ethnicity data in Medicaid to be able to look at utilization there. So data is important to be able to have that data and have high quality data to evaluate what's happening. We think about individuals with disabilities or those who are dually eligible living in rural communities or multiple chronic conditions. We do see some higher utilization relative to the population, but also thinking about additional challenges that may be there for populations, for example, who have language access needs or challenges. So using an interpreter in addition to other telemedicine and telehealth technology can present additional challenges, or if someone is hearing impaired or low vision, whether or not that technology is accessible for those individuals. Thinking about how might the change that is being implemented affect the availability of treatment and services for different communities. We've talked about in terms of some of those challenges of who's able to provide telehealth or be serving as a distance site or the origination site where patients are able to receive services, and that can also have implications for different communities and where those providers may be. As well as how might the change impact the willingness or ability of providers to treat patients. Thinking back on some of the survey data that we showed a little bit earlier in terms of some of the perceptions that providers have about whether or not telehealth is improving the safety, access, or health of their patients can have implications, and frustrations related to technology or barriers, reporting requirements, other things that may decrease their willingness to provide those services. And also when we think about the distribution of where providers are who may not be utilizing telehealth as much as others, who are the patients that they're serving, and what does that mean in terms of the impact of those ability to access services for those individuals. Again, the data, we can't measure and improve what we can't improve what we can't measure in terms of our data and options there. So how are we going to be able to look at that in real time, or are we looking at claims that may be lagged, for example, and the resources needed to implement the policy may be different based on the population and the needs. So again, thinking about equity of giving everyone what they need and not the same thing. And then lastly, how have we engaged the communities that we're trying to help with this policy? Making sure that they understand what's available to them. Also, in some of that survey data, it's kind of interesting, providers lifted up the digital literacy as a challenge that they perceive for their patients. And so how do they help, or a lack of awareness about the availability of services via telehealth can also be a challenge, and similarly helping to connect providers to resources that are out there. So if you go to the next slide, when we think about putting this together, again, I've lifted up some of these and thinking about equity considerations, accessible technology, not only for individuals with disabilities from a patient perspective, but also language access, some of the challenges associated with the initial investment, upgrades, and whether or not there is staff there to help support that, the training and maintenance of equipment, having some of those resources available but not able to be upgraded. Of course, where you live matters. So when you think about broadband access and other challenges, again, the provider availability for distance sites, some of those challenges that providers have, particularly in the case in some places with behavioral health, reimbursement, patient needs, and of course, data collection, analysis, and reporting. The other thing when we think about patient needs is the notion of wearables and who can afford those. And so what is the access to things such as Apple Watch or Fitbit or whatever the case may be? If we're thinking about individuals at the poverty level, reminding that that is less than $13,000 for an individual, or for $26,500 for a family of 4. So access to wearables and other things that can help to monitor and engage, and uploading that information to providers, or integrating that, again, as we saw, one of the perception barriers that providers have with regards to the integration of that information in the electronic health record or in other places to help it be usable and interoperable. There are also sometimes challenges related to the data sharing in other care settings, schools and other places where some of the privacy rules make it challenging to share that information that disproportionately has impacts on different communities. So lastly, to wrap up, if you go to the next slide, just some things that I think we still need more to know about and sort of research on the variation in provider types of telehealth utilization and the patients that they serve. So looking at that linkage again, who's not utilizing this, who are they serving, and what is the impact that that has on access to care and quality and outcomes. I think understanding both from a quantitative and qualitative perspective are improving our understanding of those experiences of different provider groups, size, location, resources, what does that mean? How do we help to remove some of those barriers to promote more telehealth utilization among rural providers? And developing a research agenda to explore the quality of service provided. I mean, we look at there's a lot of data looking at patient outcomes. We know that Project ECHO has been very well studied, but looking at some of the other ways in which provider-to-provider telehealth takes place, I think we have more gaps in our knowledge. And again, do the services and how that varies by patient demographics, preference, and other spaces. For example, when I think about the CMS proposed rule for doing audio only, will we see some differences in the patients that are utilizing that or being offered that for that matter? I think when we look at what that telecommunication and telehealth has looked like, it does vary. And I think we have some questions about how that varies for different groups. And finally, I think, the last two is conducting some research to increase our understanding on the relationships of the cost of care for telehealth, health outcomes, and equity. There are sometimes in our efforts to reduce costs that can create challenges for communities that have already had low access to care, and that it may be that, a little bit of cost may not be a bad thing in some cases. And then finally, developing a research agenda to evaluate which changes remain following the public health emergency and what impact they have on access and equity, particularly for our provider community. So with that, I will stop and thank you for inviting me to speak today.
Thank you so much, Dr. James. That was a great presentation. We really appreciate your health equity perspective on rural telehealth, so thank you so much. If you could hang on for another couple of minutes, we will now have a brief discussion period moderated by Dr. Mary Wakefield, our panel chair. And to our audience, thank you for continuing to send questions through the Q&A pod that you might have for Dr. James or even any of the previous speakers today. Thank you. Go ahead, Mary.
Thanks, Kate, and special thanks to you, Dr. James, for joining us today. What a great overview, and really just incredibly important from my vantage point, at least, and I'm certain of my colleagues that sit on this panel, to get best thinking about the questions around equity, disparities. In what cases might telehealth exacerbate, minimize? You talked, and it was an area I'd not really thought much about, from the provider perspective as well, and not just from the patient perspective. So all by way of saying you gave us just a lot to think about, and so thank you for that. What I want to do now is to turn to my fellow panelists and see whether there are questions or observations you would like to share or ask of Dr. James. And as we have time, we'll, as we always do, we'll turn to questions from the audience, but first from fellow panelists. And as we've done before, would you please just feel free to jump in, and if we've got a couple of folks talking over each other, I'm sure one will back down and the other will come, and we'll come back in just a minute later after the question has been answered. So again, straight to my peers and colleagues on the panel. Do you have questions or observations for Dr. James?
Mary, this is Velma, and I do want to thank Dr. James for just an incredibly rich presentation. And so much of what you said brings in the humanistic aspect of this area that we're talking about. And I was intrigued by your qualitative data, or really your data that was asking questions about providers' perceptions of this service and showing how dissatisfied they were. And what I wondered is the value of, so the thoughts about adding to your findings, or do you have any qualitative data that can give insights onto what was so dissatisfying for them? And if not, it would be great to me to know that, because it will allow us then to understand what needs to be addressed in the context of telehealth. And so I'm just wondering, is it only quantitative data, a survey completion, or do you have some qualitative data to add richness to these findings?
It's a great question, and one of the challenges that is largely survey data. It does delve into a few other things that were just not there. I didn't have time to go into, but it does talk about different specialties and sort of their perceptions as well. So OB as well as medicine and other spaces. I think, thinking about that time period, so last July to August, in terms of when people were beginning to ramp up and just things really hectic and how they were getting forward. Lack of training, lack of the technical support to figure things out, increasing levels of frustration with that. I think it would be really interesting to delve more into why there was the feeling that it is not adding to patient safety, as well as to improving some of the access to care or the health outcomes. I think those are still questions that are worth delving into, but I don't have too much more to add to that, unfortunately.
What should we be asking, do you think, based on what you've been able to garner from what the providers are saying? What should be some of our questions beyond what you've discovered in your work?
I think there's still more to be explored in those differences by specialty. There have been some that have been quicker to adopt the utilization of telehealth, I think, than some others. What are some of those challenges? What are those experiences that they are having? I am very interested in some of the smaller practices that may not have, when you look at what some of the recommendations are for how we do this better, having dedicated staff who can help with the training. If you're in a small practice, that may not be a practical solution for you. So what is the workaround for that so that you can get the most out of that technology? And again, how does that distribution differ for different patient population groups and different types of provider groups?
Yeah, I too love your health equity lens, and I also love the fact that you brought up a fundamental issue that we haven't really discussed thus far, and that is digital literacy. So there's an assumption that if you bring it, people can use it, but not really how do you train people to use it. So I appreciate both of those, and I'll stop because we have several other members of the panel.
So my question sort of follows up on Velma's, because I too was very surprised by the satisfaction data from your survey. And I was wondering, within the context of the survey, do you think your respondents were talking about provider to patient telehealth, or do you think that that dissatisfaction also included provider to provider?
Yeah, so one clarification, I didn't actually do the survey. That's survey data that was done by others, but it does include provider to provider. It's a much smaller portion. So there is, and I didn't show the slide because it was actually a lot, but it actually asks exactly what type of provider, what type of telehealth services they're doing. Most of them are for patients. The proportion who were doing provider to provider consultation was much smaller than the overall population. So I think there's a lot more of it sort of in that space of the patient. I would say, based on the sample size and the responses, it would be really difficult to pull out and look just at those who were doing the provider to provider space, because the overwhelming majority of people were doing more provider to patient.
Okay, thank you.
Are there other questions from other panelists? Thanks, Becky. Thanks, Velma. Other questions or comments?
Yeah, I have a question. And again, I love your health equity lens and really great presentation. And this is a little bit beyond the scope of your presentation, but I was wondering if you see similar disparities in sort of interest in and willingness to adopt telehealth from the patient perspective. We know that medical mistrust is a huge issue in health disparities, and I'm wondering if those play out similarly with telehealth. So, minoritized communities may be reluctant to embrace telehealth, or just curious your thoughts about that.
Yeah, it's a good question. More of what I have seen has been sort of the lack of access to it from that perspective, rather than sort of an unwillingness to utilize the technology once it's there. I think it's one that more of the conversation that I have seen over the years has just been the lack of availability. So when we think about, and I think that digital literacy is an important piece, because when you look at internet utilization in homes where the adult has a high school education or less, there's much lower rates than those who have more education. So I think there is some I don't want to call it unwillingness, just trepidation or just lack of knowledge as to how to use some of it. But it is something that would be worth looking into more.
Thank you.
Other questions from the committee? So, Dr. James, I'll ask you a question from the audience then, and it is this: low rates of vaccine. So mentioning low rates of vaccinations in rural areas now. When you think about that challenge, do you see potential for teleeducation, telecommunity services, or other innovative approaches to address that seemingly thorny issue that's prevalent in a lot of our rural communities, that is vaccine hesitancy? Thought?
I do think there is that opportunity, again, sort of who the trusted messenger is in terms of who's reaching that community. I think there can be opportunities to pull together those different pieces. But again, it's who's giving that message and giving people that space to ask questions and thinking about it in a safe space as well, where they can question and not feel that they're being whatever. But I think there can be innovative ways to do that to help get the message out and reach people.
Great, thank you for that. Sort of a last call, if you will, to my colleagues on the panel for any last question or observation to share with Dr. James before we let her go. Anything? Okay, then we are right on time, not keeping you even 1 minute late. So it's just a pleasure to have you here. Thank you very much, as always, for those great insights. And I'm going to turn it back now to Kate Winsek. Thanks.
Great. Thank you, Dr. Wakefield, and thank you, Dr. James, for joining us. So we're now going to kick off key question 3, which is our last session for today. Key question 3 is, what strategies are effective, and what are the barriers and facilitators to implementation and sustainability of provider-to-provider telehealth in rural areas? We will hear from 3 presenters on this key question, and following the presentations, we'll hold a discussion session as we've been doing with Dr. Wakefield. So first, we'll hear from Dr. Dana Womack from the Pacific Northwest Evidence-Based Practice Center, and she will present the findings from the systematic evidence review for key question 3. So Dr. Womack, go right ahead.
Thank you, Kate. I'm Dana Womack, an assistant professor at Oregon Health and Science University, and as Kate mentioned, a member of the Pacific Northwest Evidence-Based Practice Care Team. In this presentation, I'll share findings from key question 3 that's focused on the strategies, facilitators, and barriers to provider-to-provider telehealth in rural areas. Next slide. My disclosures: I have no financial interest to disclose. Our evidence-based practice team takes responsibility for the content of this presentation, and we acknowledge that this work is funded by the NIH Office of Disease Prevention through an interagency agreement with ARC. Next slide. First, we'll review the question and definitions. Next. In this third evidence review presentation, we shift our focus from the use and effectiveness to the implementation and adoption of provider-to-provider telehealth. The question we're addressing is, what strategies are effective and what are the barriers and facilitators to implementation and sustainability of provider-to-provider telehealth in rural areas? Next slide. Implementation of provider-to-provider telehealth is a complex process. It involves practice change, new ways of delivering care, and new ways of staying current with the latest medical knowledge. Our purpose in Key Question 3 is to identify barriers and facilitators that impact implementation and adoption, and identify strategies for sustaining provider-to-provider telehealth in rural areas. Next slide. Our definitions of key terms are consistent across all key questions, but for anyone who may have recently joined this workshop, we'll review them briefly for completeness. In this systematic review, we define telehealth broadly as the use of information and telecommunications technology to deliver care across a geographical distance, using multiple telehealth modes, functions, and clinical indications. We then narrow this focus in two ways. We focus on provider-to-provider telehealth, defined as interactive support provided to professionals as they deliver care, and then we included studies that are specific to rural settings. Next slide. Next, we'll review the methods that we use to answer Key Question 3. Next. The systematic review methods used in Key Question 3 are consistent with the methods described by Dr. Totten yesterday in the first evidence-based presentation. A detailed description of the methods are available in the draft evidence report at effectivehealthcare.arc.gov. Next. There are, however, several methods that are specific to Key Question 3 that we'd like to highlight. For this question, we included studies that are either comparative or descriptive. You may recall from Dr. Totten's presentation earlier that when we were looking at effectiveness, we did require that there was a comparator. We relaxed that requirement for this question because in the existing literature, studies of the adoption of provider-to-provider telehealth are often qualitative in nature and focus on a single site or program. And then to create a synthesized description of this qualitative literature, we abstracted facilitators and barriers from individual publications and mapped these to standardized implementation constructs with dual review of both the abstraction and mapping processes. We then used this mapping to visually depict the frequency of reports of facilitators and barriers across included publications. Next slide. Next, we review the results for Key Question 3. Next. We identified 53 studies in 57 publications that met inclusion criteria for Key Question 3. Approximately half are based in the United States. We use these studies to collectively assess the barriers and facilitators that have been encountered in implementing provider-to-provider telehealth for rural populations. As our inclusion criteria were broad, studies represent a range of topics and methods. Many of these studies are program evaluations that combine data from several sources, such as site visits, observations, surveys, and interviews. Others were qualitative research studies that analyze interviews, focus groups, or documents, and then categorize or catalog specific barriers and facilitators to either the initial implementation, ongoing operations, long-term sustainment, or spread of the use of provider-to-provider telehealth. Next slide. We'll take a moment to review a summary of key findings before we step through the results in a little greater detail. First, frequently mentioned facilitators and barriers are similar across settings and uses of provider-to-provider telehealth. The two most frequently mentioned constructs were access to resources and access to easily digestible information about the intervention and how to incorporate it into daily work. Any change in practice is complex, and this is certainly true in implementing telecommunications technologies to provide rural clinicians with new support from clinicians located many miles away. Often, these consulting providers are located in urban areas, and they may not be familiar with the unique challenges, limitations, and resources that are available in rural areas. Establishing this shared understanding is important. Implementation of provider-to-provider telehealth requires significant effort both at the time of an adoption, but it also requires ongoing care and feeding. This can be a challenge given limited resources available in rural settings. Some uses of provider-to-provider telehealth are highly practiced because they're used frequently, while others are not. In these cases, technology and training support may need to be tailored to frequency of use. Next slide. While qualitative data provides a rich and deep perspective into the implementation processes and experiences at individual sites, study authors use many different terms to describe the experiences, facilitators, and barriers, and this creates a unique challenge when you're trying to summarize these data across publications. So to address this challenge, we use the Consolidated Framework for Implementation Research, or CFIR, to reduce and organize the data and to support analysis of patterns of facilitators and barriers across the included publications. CFIR is an implementation framework comprised of 39 constructs organized across 5 domains. The CFIR framework synthesizes terminology and definitions for constructs associated with effective implementation from multiple sources, including Rogers' Diffusion of Innovations theory and many other sources. Next slide. The 5 CFIR domains provide a useful grouping of constructs, and also the domains represent aspects of an implementation that require thoughtful attention and planning during deployment of provider-to-provider telehealth. In Domain 1, Intervention Characteristics, this domain reflects characteristics of the intervention itself that can influence implementation success. Constructs in the outer setting domain characterize the context surrounding the implementation. Inner setting constructs represent factors within an organization that's adopting the new intervention that may interact with one another before, during, and after implementation. Characteristics of individuals is a domain that characterizes the actions and behaviors of people that influence the success of an implementation. And surrounding all of this is the process domain that includes constructs that characterize action steps before, during, and after the implementation, including planning, engaging, executing, and evaluating. Next slide. It's helpful to note that for constructs can be facilitators or barriers, depending on the context and depending on their presence or absence. The majority of included applications reported both facilitators and barriers. We abstracted 193 facilitators and 135 barriers and mapped these to 19 of 39 possible CFIR constructs. And we'll review these constructs in the next 2 slides. Next. The facilitators and barriers we abstracted map to all 5 CFIR domains. In the domain characteristics of individuals' knowledge and beliefs about the innovation were reported most often as a barrier to implementation. In the inner setting domain, facilitators and barriers map to 8 constructs that reflect access to resources and information, and constructs reflecting organizational change, climate, and readiness for implementation. Next slide. In the intervention domain, the cost, adaptability, and complexity of provider-to-provider telehealth were reported either as facilitators or barriers. In the outer setting domain, utilized constructs reflect patient needs and external policies and incentives. In the process domain, facilitators and barriers map to 5 constructs reflecting planning, engaging stakeholders, establishing formal implementation leaders, and evaluating the implementation. Next slide. Across studies, the CFIR domains utilized most frequently are the inner setting and process domains. Less frequently, facilitators and barriers map to constructs in the outer setting, intervention characteristics, and characteristics of individual domains. Although we should be careful to acknowledge that frequency may not directly equate to importance, these findings do suggest that access to resources and information, leadership, implementation climate, and readiness for implementation are influential factors in the successful adoption of provider-to-provider telehealth in rural settings. Next slide. Facilitators and barriers map to 19 of 39 possible constructs in the CFIR implementation framework. The constructs utilized most frequently are available resources, defined as a level of resources dedicated to implementation and ongoing operations, including money, training, education, physical space, and time. and access to knowledge and information, defined as the ease of access to digestible information and knowledge about the intervention and how to incorporate it into work tasks. Other top 5 constructs reflect social networks and organizational communication, compatibility or fit of provider-to-provider telehealth with workflows, and engagement of key stakeholders. Next slide. After we abstracted facilitators and barriers and mapped these to standardized CFR construct, we used a Sankey diagram to visually represent the relative frequency of construct use as well as frequency of use as a construct as a facilitator or barrier. So directing your attention to the right-hand side of this figure, we see that across publications, facilitators at 193 were reported more often than barriers at 135. The very left-hand side of the figure contains a list of utilized CFR constructs. The top 5 constructs by frequency are outlined with a blue rectangle. The number next to each item on the left is the number of times each construct was reported as a facilitator or barrier. The width and color of the lines flowing out of each construct proportionally reflect use of the construct as a facilitator or barrier, where green lines flow to facilitator and red lines flow to barrier. So to walk through a concrete example, let's look at the very top left construct, where we see that reported facilitators and barriers map to the construct access to knowledge and information 51 times. By visually comparing the width of the green and red lines flowing out of this construct, we see that in most cases, access to knowledge and information was reported as a facilitator. Less frequently, the lack of access to knowledge and information about the intervention was reported as a barrier. Skipping to other top constructs, we notice that engaging and networks and communications were nearly always reported as a facilitator. Available resources was reported roughly equally as a facilitator or a barrier. A top 5 construct that was almost always reported as a barrier is compatibility. This construct speaks to alignment between the meaning and values attached to provider-to-provider telehealth and clinicians' own norms and values. It also speaks to how well provider-to-provider telehealth fits with existing workflows and systems. This observation highlights the importance of addressing both human and workflow aspects of provider-to-provider telehealth. Rural clinics and hospitals are socio-technical systems in which a poor fit between provider-to-provider telehealth and existing workflows, or any mismatch between values associated with the intervention and individual clinician values, can negatively affect the implementation and adoption of provider-to-provider telehealth. Next slide. This slide provides an overview of the counts of facilitators and barriers by topic area, the number of publications by topic area, and pointers to individual publication references. The largest number of reports of facilitators and barriers and the largest number of included publications reflect the outpatient care setting. Facilitators are reported more frequently than barriers in publications focused on emergency EMS and in publications regarding education and mentoring. Facilitators and barriers were reported with roughly equal frequency in publications focused on inpatient and outpatient settings. And overall, the most frequently mentioned facilitators and barriers are similar across settings and uses of provider-to-provider telehealth. Next slide. This and the following slide contain written descriptions of the most highly utilized constructs across included publications. 4 of the top 5 constructs by frequency belong to the CFR inner domain and describe characteristics of the organization that's implementing the intervention. Inner domain constructs include available resources, access to knowledge and information, networks and communication, and compatibility. Next slide. The last of the top 5 frequently reported constructs is engaging, which maps to the process domain. The construct engaging is described as a process of involving appropriate individuals in the implementation and use of provider-to-provider telehealth through a combined strategy of social marketing, education, role modeling, training, and other similar activities. As has been noted in other presentations during this workshop, engaging key stakeholders and addressing socio-technical aspects of work during the implementation of provider-to-provider telehealth is important. Next slide. There are several limitations to note regarding key question 3. Next. Limitations related to the body of evidence include a majority of included studies are qualitative in nature and lacked a comparison group. Second, we did not find studies that directly compared implementation strategies. For this reason, our approach focused on compiling and categorizing barriers and facilitators. Other limitations are not specific to key question 3 and are discussed in other evidence presentations. Next slide. Limitations related to the method specifically used to address key question 3. Due to the qualitative nature of many studies, our synthesis of the literature is also qualitative. Mapping facilitators and barriers enabled us to characterize findings in a consistent way, but we do acknowledge that this may reduce the granularity of study observations. The frequency of reported facilitators and barriers may not reflect the significance of their importance to the implementation of telehealth. And lastly, the diversity of study methods limited our assessment of study quality and risk of bias. Next slide. We now review a summary of key question 3 findings. Next. Study descriptions of implementation experiences and reports of facilitators and barriers confirm that provider-to-provider telehealth needs to fit with the organizational mission and with the values of individual clinicians, address a specific need and be supported by clear communication, have backing from the organizational leadership, and be supported by local champions and engaged stakeholders. Next slide. While many of the facilitators and barriers reported are common to any type of practice change, several studies noted challenges that may be unique to rural provider-to-provider telehealth. Rural practices areas have unique characteristics that may be unfamiliar to consulting providers who are not from rural areas. A recommended strategy to address this challenge is to consider periodic rotations where urban providers can experience rural care delivery firsthand. Implementation and sustainment of provider-to-provider telehealth are resource intensive, and this is particularly challenging for small organizations in rural areas. Given variation in the frequency of use of some types of telehealth, technology training support may need to be tailored to ensure that infrequently used telehealth support is readily available when it's needed in practice. And lastly, we'd like to acknowledge that we anticipate new insights regarding facilitators and barriers to arise from the rapid adoption of telehealth during the COVID-19 pandemic. Our current search window extends to September 2020. We'll be updating this to October 2021 with the final report. Next slide. We encourage you to review and comment on the evidence report, which is available at the displayed link on your screen. Next slide. A review of this size certainly takes a team, and we'd like to acknowledge the full evidence-based practice team behind this draft report. Next slide. And we'd also like to acknowledge the many contributions of our federal partners at AHRQ and the Office of Disease Prevention. Thank you so much for this time.
Thank you, Dr. Womack. That was a great presentation. Okay, so we will hear from our next presenter now for key question 3, Dr. Melinda Davis. Her presentation is titled, Don't Put the Cart Before the Horse, Staffing Resources and Improvement Capacity in Implementation of Provider-to-Provider Telehealth in Rural Primary Care. Dr. Davis, you may begin.
Hi, thanks so much for inviting me here today. I think much of what I will highlight today hopefully will emphasize both what we just heard in the evidence summary, but also from the earlier speakers. So I'm Melinda Davis. I'm an associate professor of family medicine and public health, and also associate director of the Oregon Rural Practice-Based Research Network. Next slide. And I have no information to disclose, although in listening to the other talks so far over the last 2 days was thinking in qualitative research, we do often reflexivity, which is recognizing the orientation that we come from in the work. And so I wanted, like the first speaker, Joni, to really emphasize that I grew up in a rural community and spent the majority of my life in rural and frontier settings until moving to my academic appointment here at OHSU over 10 years ago. And so I think as I've been listening and thinking, that has helped not only shape what I'll share, but also how I now think about research because of this academic socialization. So next slide. So I want to acknowledge, again, we're making it through a pandemic. Thanks for being here today. I think this is something that's been critical to emphasize in all of my interactions with clinic and community partners over the last few years. Next slide. And really, I'll use some of those interactions to address this key question 3. And as I was preparing this talk, one of the things that really struck me is how we're defining provider to provider telehealth or communication in rural areas. And I looked at the evidence review and the guidance for this workshop. And one of the things that really came to mind for me is not just thinking about the important way that clinicians like medical providers or mid-level providers, physician assistants, or nurse practitioners can interact with specialists, but also how they might interact with other members of the care team that are critical in a rural setting. And we've already heard from some of the other speakers about how these might not just be clinical providers. They may include behavioral health providers, which are traditional clinicians, but it might also include other community professionals who are thinking about how we address social determinants of health or how we help patients access other aspects of care. So I think that's an important point, and I'll highlight some of that as we move through. So next slide. So really quickly, I'll give you a high-level overview of what I'm going to talk about today. I'm going to give you some information about the network that I work with and some of the provider-to-provider telehealth examples that we host or help facilitate. I'm going to give you 2 case examples from rural primary care clinics that kind of exemplify the context that we're thinking about here. I'm going to summarize some barriers and facilitators that draw directly from those examples, and then end with recommendations and advice for funders. Next slide. So we've heard from a few of the presenters, both about practice-based research networks like WWAMI, as well as the Clinical and Translational Science Award programs, some of which support PBRN infrastructure. I work with a network called OBrien. We were established in 2002. If you look at the Agency for Healthcare Research and Quality, they have a PBRN registry. There are almost 200 practice-based research networks registered right now with that PBRN registry. And PBRNs really emerged in the 1970s. We have a nice review of PBRNs in the US that was published in 2012 that really highlights how these networks emerged to help kind of bridge that gap between research and practice. There's a nice article by Westfall and colleagues called PBRNs, Blue Highways, and it's really, again, emphasizing how PBRNs are a way to bridge from the red highways, which are the traditional interstates connecting urban to urban areas, using those blue highways or the back roads that connect to the communities and clinics where people live, work, and play. And OBrien, in particular, like many PBRNs, we use a model where our main hub is based in the Portland area, but we have regional hubs across the state, which are staffed by our regional practice facilitators, many of who you see here in the pictures. And again, OBrien's mission broadly is to improve health outcomes and equity for all Oregonians through community partnered dialogue, research, coaching, and education. Next slide. So I think practice facilitation is a really important approach for PBRNs, as well as for implementing evidence out into practice. More recently, folks have talked about the need for PBRNs and facilitation to be equivalent to what we've seen in agriculture with health extension agents. Facilitation, there's a number of good resources hosted by the Agency for Healthcare Research and Quality, but really this is a profession that's developed over the past decade where it's a supportive service provided to a primary care practice by a trained individual or team of individuals. And often what facilitators are doing is they're helping bridge between kind of the academic institute where the majority of research occurs to the communities, and really listening to those communities and holding ongoing relationships with community and clinical partners that span beyond individual research studies. I'd encourage you to look at the International Conference on Practice Facilitation, which I co-lead if you're interested in learning more, or a 2012 review by Baskerville and colleagues that found that studies that employed facilitation in primary care, those clinics were about 3 times as likely to adopt evidence-based guidelines as settings that didn't use facilitation. I think the only caveat, and that's really important to the work we're doing here, is that originally facilitation was defined by ongoing relationships over time with clinics. So not necessarily on intervention-specific implementation, but really on helping build the capacity of clinics over time with a specific focus on different interventions. So next slide. So for context, what you can see here, what I hope you take home, is that Oregon is predominantly a rural state. The majority of our 36 counties are rural, which are designated here by the green. As we heard from Kelly, our speaker from Idaho, the darker green, as you move toward Idaho, those are actually frontier counties. And so depending on the definition, that's 6 to 7 people per square mile. For context, if Manhattan were frontier, there would only be about 150 people on the island. That would be down considerably from the 2.7 million that currently reside there. The other thing I want you to see is just that Oregon is representative of many of the disparities we see in terms of income, poverty, access to healthy foods, and even access to primary care when we compare rural to urban areas. Next slide. And OBrien, the network I work for, has provided a variety of provider-to-provider telehealth services over the year, although I don't know that we would have necessarily couched them as telehealth. And so it was interesting to think of that with this lens. And so in a number of our projects, we provide educational services through webinars or academic detailing. We're the hub for the Oregon Echo Network, which is delivered, I believe it's over 30 different individual topics to over 3,000 participants over the last 5 years. We also participate or support a consultation service for psychiatric consultations for both adults and kids called Opal A and Opal K. We provide informal supports through mentoring, through our both advisory board, but also through the relationships we have across the state. And in our implementation projects, through both research and technical assistance, they often incorporate elements of either provider-to-provider telehealth or, I guess, expert clinician telehealth to rural communities as well. Next slide. So I want to transition to a few case examples because I think, again, depending on where you're from or what your norm is, the reality of rural may not always be top of mind. So I'm just going to read this because the font is a little small. So this is a rural clinic, a federally certified rural health clinic that's located in an agricultural community with a population less than 10,000. The clinic has 2 locations that have been led by a physician for the last 20 years and is right-arm practice manager who supports hiring, billing, and quality improvement projects. The clinic has worked to generate reports from their electronic health record relating to various Medicaid and Medicare clinical quality indicators, but some metrics still require manual chart audits due to inadequate queries or data entry. The clinic manager has been trying to build out the needed queries, but it seems there are always competing demands. Recently, the lead clinician, he has been well past retirement age for a number of years, but he loves his community and medicine. A few months ago, he was diagnosed with a terminal illness. While they had talked about transition plans, they struggled to identify a replacement clinician lead. Now the provider has to urgently transition away from caring for others to caring for himself. Next slide. And this is another clinic that I've worked with, or a few that resemble this. This is a rural hospital-affiliated practice. This clinic, located in a frontier community, was physician-run for nearly 20 years. However, they recently sold to a large hospital system with the promise of centralized management and better work hours for the former clinician owners. In the transition, the clinic adopted a new EHR, electronic health record system, and transitioned many of their leadership staff, including losing a clinician owner to a promotion in the larger health system, and the practice manager because she didn't have the right credentials for the new system. The clinic is adjusting, but many of their frontline staff have left over the past year, in part due to the system transition and shifts in management, but also compounded by the pressures from COVID. This has presented challenges for established relationships and quality improvement infrastructure. Despite being affiliated with a larger hospital system, most of the improvement work is the responsibility of the local clinic team. So next slide. Next slide. Back one. All right, so those two cases were really meant to set up some of the common barriers and challenges with implementing provider-to-provider telehealth in rural communities. And one of the main things to emphasize is one size doesn't fit all. As we're doing this work in settings, we really need to think about, and I think Dr. Sparrow-Manson said this, is really thinking about that needs assessment. So really understanding what is the baseline kind of capacity and characteristics of the setting, and how can we really meet those partners where they're at to do this work. I think the other thing, and this was the case before COVID, but I think it's been so exemplified by COVID, is that contexts are dynamic, right? So we often think about pre-post assessments to evaluate, but in reality, especially in a lot of these smaller clinics, changes in a single staff member can have profound impacts on the whole functioning of the organizational team. And so it's really important to keep those in mind. Generally, some of the common barriers and challenges relate to inadequate time, staffing, technology, and funding, things that we really need to attend to in our implementation process. When we think about provider-to-provider telehealth, thinking about delays in terms of accessing the other side, or not having appropriate phone trees or contacts or ways to reach those folks. Staff and provider turnover, which requires rebuilding relationships or retraining professionals in those workflows. And we've already heard from many how critical those workflows are for making provider-to-provider communication work. One of the main things, and again, is that although we have implemented electronic health records in the majority of primary care clinics over the past decade, we see a lot of variation in the functionality of these EHRs. And I think one of the cautions is that most of our work tends to happen in settings with higher functioning EHRs or technical capacity. And I'll show some data later that shows how we risk, as Kara said, kind of exacerbating health equities by leaving some of these clinics with lower functioning technology behind. And then, as we've heard, there are challenges with funding for these care coordinate activities. And all of these challenges can be compounded when you're trying to connect across kind of those organizational silos or disciplinary silos where they might have varied timeframes, technology, or even funding structures. So next slide. Similar to what we just saw in the review, is that it's often two sides of the coin in terms of implementing these activities or many activities in primary care. So facilitators are things like having that stable staffing, having trained people where there's good follow through on both ends. I think, again, Dr. Manson emphasized the importance of relationships. I think that's so critical, again, in rural settings, both for implementation, but also for provider-to-provider telehealth. And that can be name or face recognition or a prior history working together. You can facilitate it by having direct numbers or messaging. And when I talked with one of my rural clinical colleagues, she said one of the things that's also really important is this willingness to leave cell for after hours, or willingness to facilitate kind of that a reinforcement of a trusting relationship, what sometimes requires reaching people outside of those normal work hour times. Time, space, and funding, technology that works, including electronic health records and internet connectivity, and then also models that work, so ECHO or those consultative services. And then having improvement support, so having capacity both in the clinic as well as potentially outside the clinic through practice facilitators or health improvement specialists, health information technology specialists to get these evidence-based interventions into practice. So next slide. So key recommendations, I think it's really important to fund adequate staffing levels. And by this, I mean both clinical providers and clinical teams, and to be ready for turnover and retraining. It's important we fund resources in terms of both interpersonal relationships and linkages and technology, and then to fund quality improvement infrastructure, both internal to the practice as well as external. Next slide. And this is from a study we did. It was looking at how Medicaid accountable health organizations or Medicaid health plans partner with clinics to implement interventions to improve colorectal cancer screening. But it just emphasizes something really critical. It highlighted, we found the importance of relationships and partnership, having data that was actionable and could be shared, and then having that quality improvement infrastructure and process, both in the clinic as well as through external supports. But what I want you to focus on is the circle here. And what we found are these unintended consequences. One of them being that when we incentivize certain improvement activities, there might be a tendency to focus on larger clinics at the exclusion of smaller clinics, many of which are in rural areas. And so we have to be really mindful that as we're doing this work, and again, I think Kara set this up perfectly, is that we're attending to rural clinic variation. Otherwise, we risk potentially exacerbating some of these disparities. Next slide. This is just to highlight that rural clinics are diverse. In Oregon, about 14% of the practices are FQHCs, about 12% are RHCs. But that means that we have a number of clinics that are not federally certified. And we've talked about funding, but I don't think we've necessarily talked yet about how funding structure for these different clinics vary. And so I think that's something, it's not my area of expertise, but I think it's something we really need to think about too, as we're thinking about levers for implementation and sustainability. Next slide. And because we're thinking about research opportunities, this is a quote from an editorial in the Annals of Family Medicine that came out after the first ARC-funded Evidence Now initiative. And it just says, the research study offers free assistance, but making use of the assistance requires unpaid labor from physicians and staff. Unlike payers such as the Medicare and health insurance companies, the funding agency cannot provide funding to practices to support their QI efforts. Small primary care practices have no organizational slack to put unpaid effort into activities that are not likely to have immediate payoff. An offer to give free swimming lessons to a drowning person, no matter how well-intentioned, may not be enthusiastically received. Just get me out of the water. So I think next slide, as we do this work, we really need to be paying attention to context. And we can support this work, both implementation and sustainability, by attending to staffing, technology, and interpersonal resources and that QI infrastructure. I think we need to be really cognizant of the context and the diversity within our rural practices. And that might mean that we need to take different supportive structures or funding structures to make these interventions work. Next slide. And these are just a few recommendations that I wanted to put there based on this work. So I think we have the opportunity to evaluate the impact of staffing levels on provider and staff retention, resilience, and quality of care, as we've heard, as well as on provider-to-provider telehealth delivery. I think convening interdisciplinary groups to help define some of the concepts, as others have pointed out. I really want to highlight this opportunity for observational research. We have a publication in the Journal of Rural Health in 2017, which really highlights ways to partner with rural clinics around cancer care research. And I think that would really speak to the opportunity here. But I think it's not just RCTs that we need right now. We really need qualitative work, observational work to understand what are those bright spots, where is it working, and then how can we build interventions to scale that more broadly. Novel patient payment methodologies, and then exploring different implementation support models. So last slide. Thank you so much for the opportunity to present, and I look forward to the discussion that'll follow.
Great. Thank you so much, Dr. Davis. That was really a great presentation on barriers or facilitators. We appreciate it. Okay, so our next and last presentation for today will be on the topic Adopting Telehealth Initiatives, Community and Technology Perspectives, and presented by Dr. Mary Joy Garcia-Diaz. Welcome, Dr. Garcia-Diaz. You may begin.
Thank you so much. My name is Mary Joy Garcia-Diaz, and I am a nursing informatics specialist working in one of the academic medical centers here in New York. I am also the immediate chair of Kalusugan, which means Health Coalition in our Tagalog language. And my topic is really focusing on barriers and facilitators in the implementation of telehealth projects, particularly in the use of mobile devices and remote patient monitoring. Remote patient monitoring refers to specific technology to facilitate the interaction of clinicians and patients at home, but how we utilize it will provide a different view on how can we apply the principles of remote patient monitoring within the hospital walls and at the same time follow up the patient care when they transition back to home. So my perspective will include some of the lessons learned from the community-based participatory research that I also have implemented in the Filipino-American community, particularly in urban poor areas, which may have similar challenges to populations in rural areas from an access perspective. So next slide, please. I have no relevant financial information to disclose. I'm a full-time employee of New York Presbyterian, but the opinions here is really coming from my experience in implementing these projects. I do have community projects that were funded from the Centers for Disease Control and Prevention and NIH, and I don't have anything to disclose from the electronic medical record perspective. Next slide, please. So based on the projects that I have implemented at work and in the community, my focus will look at the implementation process and describe the outcomes and lessons learned in improving care using remote patient monitoring, particularly following up discharge care of patients diagnosed with hypertension and diabetes, and also identify opportunities where this can be applied in rural areas based on this context. I will also share the outcomes and lessons learned in supporting patients transition back to the community through remote monitoring. Next slide, please. As a background, in 2015, I conducted a feasibility study in the Philippines in improving childhood immunization in rural areas as part of my dissertation study at Case Western Reserve University. We know that today's healthcare is best described as technology-enabled, with consumers driving the changes while clinicians continue to incorporate new technological solutions in our practice and daily lives. Given that 59% of US adults, including older population, owns a portable device or go to the internet to access information, the use and adoption of mobile technology has really increased in healthcare. I know that I could have done the study here in the United States, but I opted to do it in the Philippines in the hopes that the outcome will help in identifying barriers in using telehealth in developing countries, particularly in rural areas, and compare the outcome of studies here in the United States. Next slide, please. The outcome of the study confirmed existing findings that text messaging is an effective communication tool and can be easily adopted even with low literate individuals. It is portable and low cost and did not require a lot of training, being that both the patient and the community health workers are proficient in using smartphones. However, the reality also confirmed barriers to support the success of this type of program in rural areas where there is inadequate network. Not everyone can pay for monthly subscriptions, and also the clinic is still using paper records and there is limited number of workstations. So the infrastructure is not adequate to support a full telehealth setup where providers can communicate directly to the patient using their smartphones. And the patient may be located in areas where there is not enough broadband to connect. Next slide, please. Between 2015 to 2018, as immediate chair of Kalusugan Coalition, which is a nonprofit organization established on improving the health of Filipino American community through network and resource development, educational activities, research, community action, and advocacy. I worked with NYU Center for the Study of Asian American Health in implementing Project REACH-FAR, which is racial and ethnic approaches to community health, and the Keep on Track Train the Training program to prevent hypertension and promote healthy living and healthy eating. This was implemented in faith-based organizations in Queens. The study added to the existing literature on social support constructs and that the influence of cultural belief can improve self-efficacy in managing one's health and well-being. The study's findings validated the model minority myth for Asian Americans that some individuals may not be able to afford insurance, and people rely on referrals from their friends in trying to find a provider that can take care of their health needs through free clinics offered in the community. The study also identified that establishing trust with community leaders facilitated the adoption of programs with the congregants. We also noted that engaging with younger members facilitated the dissemination of educational materials through their church social media outlets. Next slide, please. I have implemented several projects that focus on workflow automation using mobile devices. We have evaluated the integration of physiologic clinical alarms to flag clinicians taking care of adult and pediatric population who are critically ill and find the right balance in minimizing alert fatigue. These include setting up group text to care teams or designing targeted text messages to send critical lab alerts or critical physiologic alarms to clinicians. In 2017, we piloted the use of remote clinical surveillance in the emergency department. The scope of the project is to minimize alarm fatigue and provide support to ED nurses by remotely monitoring patients who are on hardwired monitor. From July 2017 to December 2019, a total of 23,827 patients were monitored in the ED, and the number of patients that required intervention is around 5,720. This pilot study provided some lessons learned in terms of good catches. Some examples of good catches prevented patients to deteriorate. For example, patients who has good waveform, but their oxygen reflected around 58% and a heart rate of 160, facilitated early escalation, and the patient was quickly placed on a CPAP, and the oxygen saturation went back to 98%. Another example is a patient on supraventricular tachycardia with heart rate of 175. The patient was given amiodarone and transferred to the ICU because of the result of the timely escalation by the remote nurse. The pilot study resulted to these escalations and intervention, preventing further deterioration of patients. This also promoted better communication and collaboration between providers and improved the care coordination of patients in a proactive manner. Patients were transitioned to the inpatient unit or the ICU or eventually discharged. We also learned the importance of having a dashboard that provides a quick snapshot of the patient in monitoring several data points, therefore improving provider-to-provider communication. I was able to use this experience in our organization and have implemented the use of mobile devices. Communication can be synchronous or asynchronous, but it becomes complicated when the project is assessed for scope, timeline, and budget. Within the project scope, the workflow can also contribute to another layer of complexity. One of the critical outcomes that we need to consider is training staff in order to ensure success. The communication workflow needs to be mapped closely, so this way the on-site and remote clinicians are able to communicate quickly and or direct the escalation process to the appropriate providers. Clinicians saw the potential benefits and also the need for dedicated staff to flag this type of escalations. Next slide, please. In 2018, our organization also looked at ways to improve the care of newly diagnosed hypertensive patients and diabetic patients. I worked with our telehealth team in providing guidance with the clinical workflow processes. The project lifecycle process was followed similar to the first pilot study that we did with the clinical surveillance in the ED. And this time we also included the labor and delivery department. In May of 2018, there was a citation in regards to the urgent need to reduce severe maternal morbidity and mortality in the United States. ACOG released a committee opinion on the fourth trimester, referring to the critical but often neglected postpartum period. They proposed restructuring the postpartum care from a single visit at the 6-week mark to an ongoing process with services and support tailored to each woman's individual needs. So in this pilot study, we included postpartum patients who was diagnosed with hypertension. This required coordination with various team members. We needed clinical content experts to help define the inclusion and exclusion criteria. We also coordinated with the patient experience team in recruiting participants with the pilot study. It's also important for us to set up the equipment for the patient who will need to facilitate the monitoring of their own blood pressure and glucose at home. This required clinical coordination, setting up the connectivity with iPad devices. So this way will allow the patient or designated caregiver to enter the values generated from their blood pressure and glucose machines. Once the connectivity was established, the patient is added to the list of patients being monitored remotely. Next slide, please. In 2019, as part of my community work, I got involved in facilitating the patient-centered outcomes research. The focus group study is to engage and leverage the role of nurses in the community in understanding the barriers and facilitators of health to inform research for Filipino Americans. The findings confirm that the top health issues are hypertension, diabetes, stroke, cancer, stress, asthma, depression, and obesity. Specific questions on barriers identified long waits in the emergency department, challenges in making appointment at convenient time due to work and family priorities, and some voiced their concerns to have someone to speak on their behalf is really beneficial. Slide 10. Next slide, please. The reason I included that information is because the fact that the study of the PCOR project highlighted similarities in the needs of urban poor and underrepresented communities, similar to the needs of population that reside in rural areas. The disease conditions in urban and rural population health indicate the same concerns with access and in the management of hypertension and diabetes. We learned from the remote patient monitoring study that patients who are newly diagnosed can be transitioned back and followed up and managed effectively to avoid readmissions. So we actually targeted the specific conditions on the left side of their screen, heart failure and diabetes. Coordinating patients' education and teaching them how to use the tools are really important. As at the same time, we need to consult with our clinical content experts in identifying the parameters and assigning weighted criteria in terms of the design of the build of the algorithms that will determine the workflow processes in communicating and escalating significant and critical information to the providers. And these parameters that the patient needs to monitor from their end looks pretty simple, but for patients that might not be able to understand the importance of it, they might not be able to comply with the request. So as you can see here, the difference in this pilot study with regards to the ED remote patient monitoring is that this involves now the participation of patients in terms of completing a reflex survey that they have to fill out daily. The data is transmitted to an e-care coordinator, and depending on the scoring values, CRN prioritizes which numerical value requires escalation and further communication to the provider. As part of the clinical outcomes, the key component is really explaining the workflow and providing buy-in from the practice side, as this is key in identifying who will be receiving the escalation, whether that's going to be through email, and who will be available to receive escalation calls, especially during off hours. Our emergency physicians were very impressed by the clinical call center nurses. Pertinent details were presented during the escalation calls, and 100% of these calls were resolved successfully for both urgent and non-urgent workflows. Next slide, please. So prior to the pandemic, the pilot studies we have initiated in the patients in terms of following up discharges from ED proved that it reduced readmission, and it did have positive feedback from our providers. For example, the trends that they see with the remote patient monitoring makes it easier for cardiologists to change medications and encourage physical activity. Patients feel comforted that the heart doctor is seeing the information every day, and if something bad happens, that the doctor can see it. Similarly, for our pregnant moms, they feel reassured that there is a team of professionals working together to keep them and their unborn baby safe. So during the height of the pandemic, the use of virtual visit was adopted internally. We looked at roles and responsibilities and guidelines on who can be monitored and tracked using our dashboards. And that includes several data points that could use predictive analysis in terms of trending the data. Next slide, please. At our recent Digital Health Operations Institute, providers also shared how they use telemedicine during COVID-19, which really is tied in with patient satisfaction. Some of the positive factors that they have identified are the quality of the audio connection, as well as the video connection, including the ease of talking with each other over video, and also providing timely reminders prior to the call to make sure that the technical setup is already being completed, and also connecting before the visit and before the schedule was going to begin. However, there are also some areas where patients have experienced poor connectivity and noted extended wait times before being seen by the provider. Next slide, please. So there are also implications that I would like to include in terms of how telehealth is being implemented, and connecting this in terms of the role of our advanced practice nurses who are practicing in primary care or specializing in diabetes or women's health. The recent Future of Nursing report recommendation stated, eliminating restrictions on the scope of practice of advanced practice registered nurse and registered nurses so they can practice the full extent of their education and training will increase the types and amounts of quality healthcare services that can be provided to those with complex health and social needs, and improve both access to care and health equity. We know that removing barriers to nursing scope of practice and valuing our nurses' contributions, these are really a big part of the strategy to advance health equity and also improving care in the rural areas. So when these things are really addressed through policy, more people can have access to primary care. Next slide, please. So the other lessons learned that we have is, of course, interoperability and navigation. There is robust data that can be pulled from various devices, such as our physiological alarms, our electronic health record, using dashboards and visualization tools that can allow providers to escalate patients' condition and promote communication and consultation. We know that the pandemic highlighted the usability of interactive communication technology that is already in use but were quickly adopted. We have seen an increase in using Zoom, Snapchat, Google, and other types of communication devices. We also pivoted quickly in providing access and security to allow providers and clinicians to access charts all across the enterprise. We also know from the community-based participatory research that we have implemented that the role of the navigators is really important. And this was highlighted during the pandemic. Within our organization, we have utilized our nurse leaders across five states in New York, New Jersey, Texas, California, and Hawaii in terms of checking and mobilizing our nurses, ensuring that they're okay during the height of the pandemic. The care team is also important in the implementation of technology-based solutions, particularly for remote patient monitoring, as we know that we can replicate the utilization of portable devices and other connected devices in improving provider-to-provider communication. The key role is really in including end-user design to improve usability and adoption. Next slide, please. So I hope my perspective brings opportunities to reimagine other use case scenarios in engaging with our community and other subject matter experts to facilitate telehealth and improving provider-to-provider communication. Thank you for this opportunity.
Thank you very much, Garcia-Dia. Dr. Garcia-Dia, we appreciate your presentation. You brought in the community and technology perspective that we haven't heard yet today, so really thank you very much. Okay, so I'll now turn over to Dr. Wakefield so she can moderate our Key Question 3 session. So we invite all of our Key Question 3 speakers back and to turn your video on for a discussion session between now and 4 o'clock. And as always, we're taking questions from our audience in the Q&A pod. Thank you, Mary.
Thank you. Thanks so much. And thanks to each of you for your remarks this afternoon. Really helpful and actually reached back nicely, I think, to one of the very first speakers yesterday, Dr. Manson. That was his comments were referenced about a half an hour ago. I think that was by you, Dana. But clearly, when thinking about barriers and facilitators, that framework that he described, our speakers now related to this third question have really interfaced nicely, and one can see that overlay with some of the characteristics that he deemed really critical in the environment to have in place in order to support the utilization of telehealth provider-to-provider communication. So this is all by way of saying that this presentation really circles back nicely, pulls forward some of that content. And so thanks so much for your remarks in this session. Let me go ahead first, as I've done before, and turn to two of our independent panel members and offer them the opportunity to ask questions and or make observations. And then I'll open it up more broadly to the panel, as I've done before. And then we'll take any questions that might have come into our Q&A and try and field those as we see them to the panelists that have just presented. So that's a sequence for taking questions in the time that we have remaining. Joanne and Jayashri, you are the two who are up. If you have a question, either one of you could go ahead and start, or an observation for one of our panelists.
So I have just a couple questions for, I think, Dr. Womack. Is she still on the line? There was a couple of comments made about two barriers, and I guess I questioned them a little bit, and I wanted to know the context that they came to this conclusion. The first one was broadband access, which arguably is could be a barrier for provider to patient. But most facilities have a pretty reasonable broadband capability, and most rural providers are employed by facilities. So number one, how real is the broadband? What's the evidence around that? And the second one is culture. I guess I was a little surprised. It feels like it harkens back to the old ivory tower that you get a specialist and they're in an academic medical center and they don't understand what the rural provider is dealing with. But most of, I can tell you personally, we're selling a service, so we make sure we understand what our customer needs before we offer a service, because they want them to be satisfied. And we have subscription services. So talk a little bit about how you came to that conclusion as well. Maybe Dr. Womack's not on the line.
She is, but it looks like she's on mute.
Okay.
Thank you. I'm here. I appreciate the opportunity to answer the question. I believe maybe broadband, maybe I don't recall mentioning it in my presentation, so maybe one of the other panelists can weigh in on that. Technology definitely was mentioned as a barrier. In some cases, includes broadband. In other cases, like I mentioned that, you know, some uses of provider-to-provider telehealth are used very often and others are used more infrequently. So if you have like something that's used more infrequently, an example would be like maybe pediatric specialty care or pediatric hospice care. Like if those systems are not maintained over time, they may be in poor state of updating and readiness for use. And so there are definitely technology barriers that exist. But I'll let some of the other panelists describe their challenges with broadband, like in Oregon and in other spaces. To the culture, there are definitely some like urban providers, that there are different levels perhaps of like trust of healthcare systems in rural areas and in urban areas, and the geographical distance, and sometimes like what you anticipate patients are able to do in an urban area may be very different than asking them to do the same thing in a rural area may be something entirely different. And this is true for providers as well, because they have a different set of like resources. In an urban area, you may have 24/7 radiologist coverage, where in a rural area, you may have much less. Would be just a couple of examples that come to mind. I hope that partially answers your question.
Yeah, I did have another question for Dr. Davis. I thought the practice referral network was really interesting. And I guess my question is, and that's harken back to a comment from somebody in the earlier session that said, you know, sometimes our research is imperfect because they don't have the research infrastructure to actually answer the questions completely. I thought that was a really interesting observation. Has anybody thought about actually making or utilizing the you know, practice research networks almost a requirement for actually doing research? So when you do research, it's probably effectively done and we can actually make some decisions about where we want to invest our resources. What's your thinking on that, Dr. Davis?
Obviously, I have some bias. I love that you're planting that seed. I think that may not have fully come through as a message, but I think it's so critical to leverage existing infrastructure, leverage existing relationships, such as through the practice-based research networks that I mentioned. And, you know, we're one of many across the country. I know Adi is going to talk about the CTSA program tomorrow. Some CTSAs fund practice-based research networks as part of their community engagement programs. Some built kind of parallel structure. There's a lot of variation. You as a leader of a health system, I mean, you also provide an opportunity, I think, for researchers to partner to reach these rural communities because of your pulse on what's really happening on the ground. I think this harkens back to the second question you just asked Dana, which is around building that trust and helping facilitate kind of that understanding between urban rural culture. Like that's the real benefit of leveraging existing infrastructure and leveraging existing relationships, is that it gives you an opportunity to communicate the reality of these settings and to communicate issues with technology or issues with broadband. To the point about broadband as well, although I think in 2016, about 50% of primary care providers were employed by hospitals or big systems. That's gone up with COVID. It's about 70% now, but that's still 30% of practices that are independent in some way. And I would think many of those are located in rural areas. We didn't hear a lot about broadband challenges at the practice level, but some clinics still struggled. There's a lot of movement that way, so I think we'll see continued improvement, but there I think still are some issues with broadband out in the community.
Great. Thank you.
Great. Thanks, Joanne. Jayashri, any questions or comments for our speakers?
My question is to the speakers would be about what would be your key recommendations for improving, telehealth provider-to-provider communication and impacting on patient outcomes. What would be your personal opinion based on your experiences, having implemented practice-based research, and Dr. Davis and Dr. Garcia, your multidisciplinary care coordination experiences. What would be your I would say recommendations for moving the field forward in terms of strategies to improve or promote telehealth patient-to-patient provider communication and impact patient outcomes? I know
thank you for that question. Absolutely. Thank you for that question. And I know that it's very challenging. I know that our assumption is that everyone would learn how to adapt technology easily. But then when you come to the nitty-gritty implementation of the telehealth setup itself, it does require some technical assistance in setting up the infrastructure, particularly with the right devices, what is their network communication process, how will you train your office staff, and at the same time, looking at the end user itself, right, our patients, how ready are they in adopting the utilization of interactive communication tools. Our assumption is that they would be able to adapt it quickly, but what we have seen in our community when we try to understand their needs, it's the younger generation that helps our elderly population in showing them the ropes in accessing the internet or even just setting up their login access. So those are some of the keys, I think, that we could look at in terms of navigating the utilization of telehealth, both from the provider and the patient perspective.
Okay, thank you. Any other comments or suggestions?
Yeah, I might add, thanks so much again for the question. I hope this came through in my presentation, but I think so much of what we need to do is to attend to some of the foundations. I think we often think of technology as something that can solve a problem, but in order for technology to work effectively, we really need to look at some of the root structures and root causes. And so I think there's a real opportunity for research to think about how do we support the diversity of practices who might have variation on reimbursement, on staffing, on models, who might have different levels of quality improvement capacity at baseline. And so I think the way we do that through research is through things like pragmatic research studies or quasi-experimental studies. I think the other thing that's really critical, we've heard a number of times that, there are small sample sizes, but rural by definition is small. And so I think we need to be thinking about methods, be it novel or be it accounting for that context. And so I think it's really exciting to see where you guys will go and what you'll recommend, and really to just emphasize that I think a lot of this work is not just about attending to the provider-to-provider technology, but really helping continue to build that infrastructure in primary care, which is so critical, or to community care, which is so critical to the health of our population.
Thank you, Dr. Davis and Dr. Garcia, for your comments and suggestions.
We'll go ahead then and see whether there are other members of our panel that have questions for the speakers. Anybody else?
I have a quick question, and again, wonderful presentations, and I really liked how all the presenters talked about context and how that affects implementation. So I have a question for Dana, and maybe I misunderstood your presentation, but one of your points was that the inner barriers were, based on current research, the sort of inner barriers were more important than the outer and, you know, the other sets of barriers. And given how we've discussed context, which would be more of an outer barrier, I was just wondering how you interpret those findings.
Thank you so much for the opportunity to answer this question. I think I would say that their context applies both to outer and to inner. So in the outer context, you have like the needs of the people that are being served by the organization and external policies and incentives. And so those all fit in outer. In inner, there's context as well. This is like the things like I'm just looking here at the constructs, the availability of resources, the access to knowledge and information about the intervention and how it fits with day-to-day workflows, networks and communications, how people are being communicated. And so all of those provide, like even your communication strategy with your key stakeholders would be like a context. So I certainly believe that the context is there, and I'd like to just reiterate that the frequency, our strategy was to map these facilitators and barriers to standard constructs and then report the frequency of those constructs. But it's, you know, frequency is not the same as importance. So it shows us that a lot of people are talking about these, and it lets us know that there's something that we should attend to. But we'd also love to see more comparisons of strategies across implementations, like, well, how does it work to do it this way versus that way? And we didn't see a lot of that in the literature. And so I think that's an opportunity moving forward to enhance our understanding of how to implement provider to provider telehealth well.
Thank you.
Great. Any other questions from our panel? There is one in the audience, from the audience rather, and it's directed to you, Dr. Garcia-Dia, but it's possible that one of the other presenters would have an observation in response to this question too, in which case we welcome that. But it's for you, Mary Joy. The question is, have you used electronic medication monitoring to assess and manage medication adherence? The individual who submitted that question indicates that they think it's an effective approach, and just looking for your comment, whether or not you've used it, and if you have a view of it as a tool.
That's really a great question. And we have not actually, although I have seen in the review of literature in terms of monitoring compliance using those type of tools, the electronic pill box, so to speak. So in terms of how that could be captured as part of the internet connection, that would be something that probably vendors would potentially explore, because that would also improve compliance in terms of the treatment and outcomes for the patient.
Thanks. Other observations about this particular question? Otherwise, I'm going to go on and share another comment from the audience. Anything from our speakers? Okay, then just want to share, and Joanne, this is probably mostly for your benefit, although for all of us, but it relates to a question that you had asked about broadband. And one of the conference attendees is saying that broadband is an issue in Wyoming, where most of their counties are considered frontier. And there are only 3 counties that are considered urban in that state. And more than half of their psychiatric providers live out of state. Those who live in state are clustered in the urban counties. So just a quick observation about that, about the issue of broadband. Any other questions or comments from our panelists? We're on the last minute now. From my colleagues on the panel. Okay, I'm not hearing any then. again, thanks so much to the speakers. Really appreciate your time and certainly your expertise. Great presentations. And Kate, I'm going to send it back to you just to wrap up today and prepare for tomorrow. Thanks.
Okay, great. Thank you, Dr. Wakefield, and thanks to our speakers at the end of the day today. So this completes day 2 of our workshop. We'll certainly look forward to our third day tomorrow, starting at 10:55 Eastern, if everybody could join a little early. And just a reminder, if you're not registered for day 3, you need to do so, register separately for each day, and you can do so at prevention.nih.gov. And I think that's it. One more day tomorrow. We'll do key question 4. We also have the keynote speaker, and then we will do a lightning round. So we will hear briefly from each of our speakers across all 3 days, a key summary from each of them to close out the day. So thank you, everyone, for joining us. We really appreciate it, and we will see you tomorrow. Take care.